Jim, I was out at your old office yesterday.
You were talking to me?
Yeah,
You were
I was at your shop. Yeah,
Really? Oh, how exciting.
I'm a loyal customer now.
Yes, well, welcome. Thank you. I hope all went well.
Oh yeah, we have we just have a piece that's rattling from the catalytic converter cover. We had to.
Oh,
Everybody's installing those covers because catalytic converters are getting stolen.
yep. Ours was stolen right in front of our house.
Oh,
And the insurance paid for most of it, but said you only get one if it happens again. So I so we're now parking at the end of our driveway down where it would be really, and it's on a real slope, so I don't think anybody's going to try it there. But oh my,
great.
yeah. So we got a one of those shields installed, slow them down.
Yeah.
Oh yeah. Well, I hope they took care of the rattle.
Well, they're going to. They got to put it
Yeah,
up and put it on
yeah,
on the rack. But yeah, they will. Yeah, it's a good group
yeah.
there. You built a good business there. It's impressive.
Oh yeah. I have to. Terica, who bought the business, started working for us when she was 17 at Benson High School in Benson High School's automotive program. Started as a helper. We sponsored her as an intern at Mount Hood Community College Automotive, and she just worked her way up,
Yeah.
and it worked out really well.
It's going strong. I know that you probably had some sleepless nights worrying about what would happen after you retired, but they're doing well.
Well, especially we retired like just a month before COVID became an issue, and I that was a real challenge. But well, you saw the plexiglass that's up, and yeah, they they've been doing all right.
Yeah. Yeah, I saw all the plexiglass in place.
Yeah.
Chicky, I'll rely on you to give us a signal when we have a critical mass of people and we'll get started. Have people had a chance to look at the agenda this morning?
Yep.
Yes.
Okay, I want to
Yeah.
give. Yes, go ahead.
This is your official signal that we are good to go to get going. Thank you.
Okay. I want to ask for a little grace this morning, and I'll explain what that's about. The legislature is going to be in session shortly, and we have some deliverables we want to get to them that we're going to talk about this morning, as you saw on the agenda. A lot of this has sort of been happening in real time, and so I want to just let everybody know Chicky and the staff were working over the weekend, late hours, I'm sure, both last week and this week, to pull together some materials for our discussion today. So if anything we do, including anything that I do as chair, is a little bit choppy this morning, the reason is that we're really working hard to get this group the opportunity to have some input on the proposals, and you see those discussion sessions on our agenda. So give us a little grace if we fumble around just a little bit in terms of the agenda. It's not for lack of effort or preparation. It's because we had a lot to cram in to the last couple of weeks as some of these proposals are coming together. And of course, the legislature gives you a hard deadline to get them feedback because they have just a 1 month session. For those of you who don't live and breathe the legislature, it's a 1 month session. Things happen quickly. So we don't have 6 months to kind of do our business. We got to do it really quickly with them. So let's jump in. Chicky, we want to start by approving the minutes from our last meeting.
Yes, we do, Dan. And before we do that, I want to make sure that we do have quorum. So I will do a quick roll call. Please let us know if you are here. And we will move over to the minutes after that. Craig Anderson.
Here.
Thank you. Dan Field, I see you. Ron Gallinet. Mary Beth Guarino.
Here.
Jim Hauser.
Here.
Good morning. Kathleen Jonathan let us know ahead of time she's not able to join today. Sean McAnulty.
Here.
Ken Preventure. And I do believe Ken also let us know he was not able to join. Thank you, and sorry about that. Shannon Saldivar.
Here.
Lindsay Shirahama.
Here.
Shauna Butler.
I'm here. Good morning.
Good morning. Andrew Stolfi.
Hi, good morning. I'm here.
And Dan, we officially have quorum.
Great. I'll accept a motion to approve the minutes from our December meeting. If anybody would like to make and second the motion.
I'll make a motion to approve the minutes.
Thank
I'll
you,
second that motion.
Thank you, Jim. All in favor of approving the minutes, say aye.
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 Any opposed? Okay, thank you. So just a quick review of the agenda. We will start, as we usually do, with Stephanie Kennan doing federal health policy updates. We'll then go to Cable, who will give us a relatively quick open enrollment update from last fall. We'll then go to Anthony Behrens, who will talk to us about a 2023 notice of benefit and payment parameters. And I'm sure he'll explain what that means when we get there. That's a technical phrase that he'll walk us through briefly. We'll have a little section for public comment. And then we'll dive in to the bulk of our work, and Chicky will introduce that. And then we'll put us into breakout sessions to talk about the public option report. Jeremy Vandehan, Tim Sweeney have been with us before. This is not our first bite at this apple, but this is a chance to revisit the community conversations that many of us participated in over the last couple of weeks. So the goal for us today, the meat of our agenda today, is to really digest what we heard, to have a robust discussion among ourselves about the feedback that we got, and then hopefully land on a series of recommendations or feedback back to OHA and the legislature. So more to come on that. That's just a high level description of what we're going to do. More to come on that, and we'll explain it when we get there. But for now, let's go through the first part of our agenda and find out, other than Justice Breyer retiring, Stephanie, I hope you're with us and you're able to tell us what's happening in Washington, D.C.
Well, thank you, and good morning to you all. I will start by saying that the White House this morning has really been pushing the message that 14.5 million people signed up through the exchanges, 10 million enrolled through healthcare.gov. They're very excited about that number, and it's going to be the message of the day until I think the press conference starts just in a couple of minutes with Justice Breyer. So some good news for the administration. I'm going to start substantively talking about the appropriations process. And if you think you've seen this movie before, you have, and you've seen many sequels. But here's where we are. The continuing resolution that funds the government ends on February 18th. We're not that far away from it. The Republicans have essentially said that if the Democrats would agree to increase spending in the Department of Defense, and if the Build Back Better Act doesn't come back and is dead, they would be willing to do some kind of omnibus. And I will say that the new phrase in DC is now cromnibus, because that would include COVID funding, and that they would be happy to fund something through the end of the fiscal year. That's the end of September. However, if the Democrats don't agree to those two conditions of killing the BBB and increased defense spending, they don't want to play. They will just do a continuing resolution till the, to the end of time, I think, until they take over. And they think they will take over. However, I'm going to tell you, Hill staffers are telling me they're so swamped with meeting requests, particularly from the healthcare sector, because of such great need from COVID-related issues, that they think there's going to have to be something. And I'll just give you an idea of some of the things that the health sector is asking for. The hospitals are asking for another $25 billion for provider relief. They're asking for protection from having to do loan repayments. You may remember the Trump administration did accelerated payments that were to be repaid. They're asking for that to be stopped. They're asking for protection of the Medicaid dish payments for hospitals, making sure they don't get cut. They're asking for, the list is long. They're asking for to make sure that the hospitals can maintain their 340B drug discount status. All of these are really crucial elements for hospitals and other providers in terms of payment and trying to make up what COVID has done to the healthcare system. I say make up in parentheses. A group of House and Senate appropriators met on January 13th. They came out. They were all, yeah, we can talk to each other. We've got great ideas. We might be able to move down the road. They've continued to talk, but there's nothing really formulating at this point. And the House and Senate are out this week, so there's kind of like no news going on. One of the bigger policy issues that's hanging out there that they would like to try to address, healthcare sector would really like it addressed, is the Medicare sequester. You may remember, you may not remember, some time ago in a budget deal, there was a 2% cut in Medicare for hospitals and physicians. It got extended, and then in the last step legislation at the end of last year, the legislation said, well, we'll not put that sequester in place. It'll end, until April 2022. And then they go to a 1% cut. And then by June, that's a full 2% cut. That would be across the board to hospitals, physicians, everybody. Healthcare groups are really trying to get the moratorium extended. They'd like to have it extended through the end of the public health emergency, which currently has been extended to April, but they'd like to, we expect it will be renewed again. So they would just like it, whenever the public health emergency ends, they would like the moratorium to be in place until that end. These are really thorny budget issues, and I won't go into all the gory detail of the complications of them all. But if we don't have a continuing resolution or a cromnibus or some sort of supplemental that funds the government by February 18th, we have a government shutdown. Nobody wants that. So we expect when they come back next week that there will be some very fast and furious discussions about how to move forward. A couple of people have said we'll probably do a continuing resolution for a short period of time and then see if we can continue to work on getting individual bills out, perhaps do a supplemental for COVID. So many moving parts, but I don't think the government will shut down. I think we will come close, as we often do, but I don't think we will have another shutdown. Just to give you a flavor of some other things that are going on, Build Back Better. I would say that it's not even on life support, it's dead, but it has parts that are alive. They just don't have any attachment to anything yet. Most of the healthcare provisions, and I say most, but not all, are not considered controversial. The drug reform price, the Medicare drug reform negotiations, the other price reforms for drugs, for example, are not considered are controversial. The tax credits, the marketplace subsidies, not controversial. So there's a number of healthcare provisions they could package up together and put with something else. Before everything blew up in December, one of the finance committee staffers had said to me, I'm willing to bet this becomes a tax bill with healthcare attached. And lo and behold, yesterday, Ron Wyden came out of some meeting and said, I think we could probably attach most of the healthcare provisions to a clean energy tax bill. So that gives you an idea of what he's thinking. We know negotiations are going on amongst all the leadership folks. Most of the staff have told me they have no idea what's being said. Everybody's on hold. Staff's getting restless and tired. And we'll have to see where it goes. But I suspect Democrats will want to try to bring back the healthcare provisions that they can get passed and attach it to something else, probably a tax bill. The problem they have is that if you remember, the House passed the Build Back Better Act through the reconciliation process. The Senate didn't act. The Senate could still act on the reconciliation process. They would just have to conference with the House on the differences. But you can only use reconciliation a couple of times, and it's time limited before you then have to have another budget resolution with reconciliation instructions. So they've got to act pretty soon, or they've got to figure out if they can pass it in regular order, meaning the 60 votes. And to be very honest with you, I don't know, but I suspect that the judicial nominations for Breyer's replacement. I'm sorry, could somebody mute themselves? Thanks. I think the judicial nominations process is also going to suck a lot of air out of the room and time. Those things are very time intensive when it comes to floor time. So that's going to make it even more difficult to get these healthcare provisions passed. Of course, they could all come back next week and decide we're going to throw something together really fast and see what happens, and then move on to judicial nominations. But I think it's going to be a little bit more time intensive than they think. We know that Manchin doesn't like the Medicaid expansion help for states that didn't expand. He didn't like family medical leave. There are a couple of other things he didn't like, so those probably will drop out, but the core healthcare provisions will probably stay. I'm also going to say to you, just to make it really a happy day, this is because it's an election year. There's sort of a saying that if it's not baked by June, it's not going to happen, which means you need to have everything that you want to do in place, ready to go by the June-July recess. They will be gone a lot for campaigning, and that means the fall will be very condensed. So if something doesn't move before June, then it will move afterwards. It really has to be all set up. I think reconciliation or whatever related to the healthcare provisions has to move before June, or it'll just sort of die under its own weight. That doesn't mean that there wouldn't be a lame duck session. There's now always a lame duck session, and healthcare has always been a part of a wrap-up bill. I think people are looking at the end of the session wrap-up bill as something for the parts that they want to try to pass that didn't make it through on the first go round. Sort of a second bite of the apple, if that makes sense. So timeline-wise, if we can get healthcare through before June, they get through before June, and then after the election, some kind of wrap-up bill with some more healthcare in it. Let me just talk about the regulatory side of things.
Hey, Stephanie.
Yes.
Before you do that, and I'll shut up in a minute and let you continue, but you just were referencing timing, and I made that little joke about Justice Breyer's retirement, but actually I do wonder how a fight over Supreme Court justice will impact the timing. You said, well, if they can get healthcare done before June, that makes sense, but Congress has this way of only being able to do one thing at a time, which is very strange, but seems to be true. So I guess I would just ask you to comment not on who should replace Justice Breyer, but how that process will impact the likelihood of what you described actually happening.
Well, there are two things that have to go on with a nomination hearing. First, they have to do a lot of background to the potential candidates. One has already gone through that process. The other has gone through the process, but is having a hearing for a different judicial position next week. So those two are done. All the FBI investigation and that kind of stuff is done. The third one, they'd have to do an intensive investigation, and that takes time. So there are two candidates that they know that they've got the homework done. That speeds things up, but it could take a lot of floor time. The hearings will have to, are long and arduous. And it isn't just the nominee that testifies. There's a whole host of witnesses who testify. We just don't see that on TV. And it could slow the process down considerably. We'll know more when they come back next week, how they're going to sequence things, and if there is any kind of idea of how to move the healthcare provisions. I mean, I was talking to a staffer yesterday who said, essentially, I'm sitting at my desk waiting for the call to tell me what to do. And that's what I've been doing all week.
Wow.
I don't know the path forward. I don't see a path forward. It's above my pay grade, and they're not talking to the staff yet. So
Gotcha.
they can do it, but it's going to be, this Senate has not worked a lot of late nights. It will be a lot of late nights.
Yeah. Thank you. Okay. Regulatory.
That's all right. I know you're going to talk more about the notice of benefit and parameters, so I won't go into that. I will just simply say that it's a letter, regulation, whatever you want to call it. Unlike past years where advocates have gone crazy about what's been in it, this year everybody was very relieved that this administration has brought a number of issues back on track. And I'll just leave that there. There's not a lot of gnashing your teeth over that. One thing that I just want to throw is sort of in the background. The ACA had a provision that requires insurers to contract with providers that just stopped short of being an any willing provider provision. It has never been enforced. And in one of the last appropriations bills, I want to say 2 years ago, Congress required that a rule had to be promulgated on this provision by January 1 of this year. That did not happen. There was no proposed rule on January 1 or January 2 or January 3. And what the administration has done instead is on January 19th, they had a listening session for stakeholders to talk about how they ought to do a rule. And so people are now expecting that a rule will come out sometime this year that will try to enforce that particular provision. It's going to be complicated because, like most of the ACA provisions, it has to go through Labor and Treasury and HHS. That always makes it harder and slower to get through. So that's something to look at coming down the pike. The other thing I wanted to bring to your attention, excuse me, is the public charge rule. This was a controversial rule proposed in the last administration concerning largely immigrants and what happens if they become a public charge, i.e. take something from a federal program like Medicaid or SNAP. And 21 attorney generals have asked that this rule be formally withdrawn. It was supposed to be formally withdrawn some time ago, and it didn't happen. The Biden administration is looking at how to rework how to view immigrants entering into the U.S. as a public charge. Like, what do we want to view them as? How do we view someone as a public charge? Basically redefining what a public charge is. And it's going to take them some time to do this. The State Department has asked for feedback on some next steps. Homeland Security is working on part of this. So there's a lot of motion and action going on. And we're expecting that maybe at the end of the year, we'll see something new that essentially redefines what a public charge is. And hopefully not as draconian as what we were experiencing when the Trump administration put out the proposed rule. That really had everybody up in arms. So that's the other thing that's coming down the pike. And with that, I'll stop because I've talked a lot today. Any questions?
We have a few minutes for questions. Sean and Craig, don't disappoint us. Craig, go for it.
Great. Thank you, Stephanie. That's great. Update as always. You mentioned the healthcare provisions. Some of them are less controversial and some of them might be like Medicaid expansion, but where does hearing for Medicare adding that benefit? Isn't that one that was in Bill Beckner?
The adding the hearing benefit, it was controversial because it was it is an expensive benefit. The House passed one benefit. The Senate said, we're not really wild about that benefit. They were restructuring it, but we never got to a point of voting on it. So it's sort of lingering and out there as a potential to be added on. The Senate version was far less generous than the House version was going to be.
Right, but how do you think that'll go forward if something does get passed? Do you think it'll more likely happen or less likely?
I think the longer it lingers out there, the harder it gets to pass a new benefit.
Okay.
If it passes, it will be a very slim benefit.
Okay, thank you.
I'll just add along those lines, there was a dental benefit that people wanted to do. And the Senate said, no, we can't afford the dental benefit.
Stephanie, we were excited about that in Oregon. We've made a lot of progress on dental coverage in Medicaid. And I didn't know that if you knew, I think as I'm looking at faces on the screen, I know a lot of us were hoping that would pass, but
well, there's always hope until the very end when they say, nope.
Yeah.
The Senate was not as welcoming of the dental benefit, even though most of the members would absolutely say there's a correlation between dental health and other health, and they get it. It's just a question of how to pay for it in Medicare.
Yeah, and Oregon, as I said, in the Medicaid program, Oregon has really prioritized expansion of dental care. And so to see that happen in Medicare, especially for low-income seniors, would have been huge. Any other questions for Stephanie? Really great update. Sean, thank you. Jump in, please.
On the public charge point, is there any discussion of that being expanded to include benefits besides the long-term care and cash benefits?
I'm sorry, I didn't hear the very first part of your question.
On the public charge point, is there any discussion of them adding additional benefits that applies to beyond long-term care and cash benefits?
I'm not sure what you mean by public charge, because the public charge rule, with the way it's out there, the public charge rule doesn't have to do with benefits. It has to do whether or not, it has to do with if you're an immigrant and you use a benefit, it starts to block your ability to become a citizen. The issue that they're trying to look at is really much more fundamental than adding benefits, so that might be of concern, or taking away benefits. It's really is, how do we want to define a public charge in keeping in the values of a country that's based on, so many of us are from, other countries. So it's really a wholesale relooking at it.
So at least at the moment, only the long-term care Medicaid benefits and the cash benefits like TANF and whatnot count towards that public charge rule. Are they discussing adding other programs into that, or is it just staying at those two programs?
Well, the way the previous administration wanted to do it was very sweeping and wanted to include much more. And that was part of the reason so many people had problems with it. And it sort of languished until the Biden administration came in and pulled it, but they haven't officially withdrawn it. Which makes a difference for folks who follow these things. So I think it's a good sign in that they are doing a wholesale re-looking at this in terms of how do we want, at what point do we say you're a public charge? I think is really the question.
So does that mean that they are considering potential new benefits being included in that new definition?
No, I think they're trying to figure out how to allow people to have benefits.
Yeah.
Okay.
And not have it count against them.
Good. Okay.
I know, Sean, there are people that would want to expand the benefits that block you from a path to citizenship. My guess is what Stephanie is describing is that the Democrats are actually trying to go the other direction.
Exactly. Thank
Okay.
you for being more articulate than I am.
No, that's okay. It's
Just wanted to be
complex.
sure that.
It's complex. Stephanie, thank you as always. Really appreciate your time and the update. And I will tell you, Stephanie, there's a number of us who are rolling off. We're appointed by the governor. This is our last meeting. So when you'll stay with Chicky and the group, and you won't see as many familiar faces next time. But I want to say it's been an enjoyable series of meetings with you over the years to get your updates, and really keeps us feeling connected and informed. So I want to, on behalf of all of those of us who are rolling off, want to thank you.
Well, thank you so much. That's really great to hear. And I
Yeah.
will miss you all.
Yeah, appreciate that.
Take care.
Okay, thank you. Cable, are you on? And do you want to give us an open enrollment update?
I am on. Thank you very much. Let me hop on camera here. Can everybody hear me? Excellent. We had a little technical difficulty getting in, so glad to see that it's resolved. Don, are you able to put the slides up for me? Thank you. So just a couple of open enrollment updates based on some December 15th data. There's some more recent stuff that came out just last night, but we didn't quite have enough time to get it in. So anyways, through December 15th, we had 146,602 plan selections, which, as you can see, is a pretty significant increase over the last couple of years. Oh, and it's actually been updated. So those are the most recent numbers. It looked a little higher than what I had before. So perfect. That is the final, as of January 15th, open enrollment update. So it's the highest we've had in, I believe, since 2018, actually. And so just kind of goes to show that that extra 30 days of open enrollment really does make a difference. So we're excited about that. We don't have any planned data specifically for enrollment yet. That will come out closer to probably April, but based on our window shopping tool that we have, the three most popular plans at the bronze, silver, and gold level were the Navigator Bronze HSA, the Kaiser Permanente Silver plan, and a Providence Standard Gold Choice Network plan. So those were the most viewed. It'll be interesting to see if that correlates to plan selections or not once we receive that data from CMS. Next slide, Dom. Again, to kind of highlight the significant impacts that the provisions had from ARPA. I mean, we've seen a decrease in, almost $70 after the premium, or after the tax credit for people's out-of-pocket premium. So that's a pretty large impact. And even more than that, it's just opened up those financial assistance opportunities to those over 400%. And we know that especially in the kind of older demographic, that does make a pretty significant difference. Once you get to a certain age with the way ratings work for insurance, those premiums get higher and higher, and your contribution percentage should stay the same. And so with that removal of the 400% barrier, some of those folks who are in that boat are now seeing some pretty significant savings. So just another kind of aspect of those provisions that, hopefully through legislation this year they can extend, because as it currently stands, 2022 is the last year for all of those provisions to stay on. So obviously it's increased enrollment, it's decreased people's out-of-pocket monthly premium expenses. So all good things for those folks who have to purchase through the individual market and on the exchange. And with the upcoming migration from Medicaid as a result of into PHE, obviously the longer those additional subsidies that lower those premiums, especially at the lowest FPL levels, the better for those folks transitioning to kind of remove some of that sticker shock that they're inevitably going to see. So that's kind of all the early data we have. Does anybody have any specific questions that I might be able to kind of answer? Again,
Cable, I would just say I appreciate this slide. Folks, keep this in mind. This has an impact on the later discussion we're going to have around other options for people coming out of Medicaid redetermination. So this is a helpful pivot point, Cable. Any quick questions for Cable? We're on a tight timeline, but Craig, go for it.
Yeah, thanks. Do you have a sense of how many are January 1st versus February 1st effective dates?
I do not yet. I know that as of December 15th, there was about 141,000 plan selections. So there was 5,000 additional between December 15th and January 15th. How many of those folks actually effectuated on January 1st? We don't typically know until about the first week of February. So I can probably give you an update in the first week of February once we get some preliminary data, but right now I don't have a good sense of 1/1 versus 2/1 start dates.
Any other questions? I see we have a question. I can't see who has their hand raised. Oh, Andrew.
Hi, good morning, everyone. I know it's not exactly directly related to this slide deck, but is there any insight into potential changes in employer-sponsored coverage where there? I know obviously the ARPA had a great effect on the indie market. Was wondering if there were more employer-sponsored covered individuals in Oregon. If there's any insights yet.
That's a question I'd have to kind of refer back to our colleagues at the Division of Financial Regulation. They track some of that data, whereas we don't track that for the market.
Andrew, we're going to have to hold on that because as Cable said, that's really DFR. I know we have Andrew Stolfi on. Maybe if Andrew Stolfi gets information, he can put it in the chat or give you maybe a point of contact to follow up on that question. It's a good question. It's just not something that folks here are ready to have that data. But it does exist somewhere. Okay, let's pivot to Anthony Behrens. If you're on, Anthony, the floor is yours.
Good morning. Can you hear me okay?
Yeah, we can hear you, Anthony.
Okay. My presentation will be brief. I'm going to talk about the notice of benefit and payment parameters. Hopefully Don has my one slide up.
Yep, we're good to go.
So I just wanted to highlight a couple or a few provisions that we decided were kind of the most important out of the provisions that were in this year's notice of benefit and payment parameters. It wasn't too exciting this year, so these are kind of the four that we thought were the most exciting, I guess you could say. So when the Trump administration was in power, they took away the anti-discrimination provisions regarding sexual orientation and gender identity. In this NBPP, the feds proposed to restore those provisions, and we strongly supported that decision, basically because it's the right thing to do and because it's consistent with OHA's goal to end health inequity in 2030 or by 2030. And then the next one we identified that was a little concerning for us. It was kind of a signal to states that the feds were looking at limiting the number of plans that carriers could offer. We opposed that suggestion because we believe that really should be determined by the states because they best understand what's in the best interests of their citizens. And the next one that we chose to highlight today is federal standard plans. So during the Trump administration, they took away the federal standard plans. That was later, that decision was later overturned by a court. They said that they didn't go through proper rulemaking. So HHS had to bring back those standard plans. They did exempt Oregon specifically in the NDPP because we have our own standard plans, and they said other states that are like Oregon would also be exempted. However, it appears that they want us to abide by their display requirements, which would require special differentiation for standard plans. We opposed, we obviously supported the exemption from federal standard plans in the state, but we opposed the display differential because we believe that while the standard plans are pretty great, they may not be the best for every consumer. So we don't want to highlight a particular plan in case, and we want to encourage consumers to shop to really find the best plan for them. And then the last provision that we wanted to highlight today is related to the quality improvement strategies. So basically, the feds are proposing that that carriers be required to highlight health and healthcare disparities as a specific topic in QIS, and how and things they are doing to address those disparities. And again, this is something we supported as consistent with OHA's goal to end health inequity by 2030. Those are really the 4 provisions that we chose to highlight today, and happy to answer any questions if you have them.
Any questions for Anthony? Appreciate that, Anthony. If there are no questions, I think what we'll do now, we can take that, there we go. And what we'll do is, we're running ahead of schedule, which is great. Let's go ahead and transition to public comment. And as always, what I'll do is I'll just hold the floor open for a moment. And if there's anybody who's a member of the public attending, would like to make a comment, it's an important part of our agenda that twice on each agenda we leave time just for open public comment so that people can feel heard. And you just simply need to raise your hand. We'll leave that open for a moment. And Chicky, if we're ready, I think if there's no public comment, I think we're ready to transition really into the meat of our agenda today, which is the follow-up on the marketplace community conversations. And what we'll do is we'll have Chicky kick us off. She can frame sort of the run through between now and the end of the meeting and how it's going to flow. And then I am just a quick heads up, shouldn't impact the discussion. I'm going to hand off the gavel to Shannon here for a little bit. And so when we get to the question and discussion section after the presentations from Jeremy and Chicky, Shannon may guide the question and input from all of us on the advisory committee. So with that, Chicky, over to you.
Thank you, Dan. So before we do head into the meat of our agenda, I had put in the agenda before this section to do a quick debrief on the marketplace community conversation. So full disclosure, starting now until the next hour and a half, we will be asking a whole lot of questions just because your feedback has been so valuable, and we want to make sure that we ask the right questions and document as it's appropriate. So starting with, how did the marketplace community conversations go? So it seemed like a long time ago, but it was actually just last week. We had 2 sessions. It was January 18th and January 20th. The first one is about the public option and the usability of marketplace plans. And on Thursdays was about Medicaid redeterminations, with a special focus on the Medicaid migration to the marketplace. It was very well attended for a first community conversations series of meetings that this committee convened. So for example, on the 18th, we had 97 attendees, including panelists. And then on the 20th, we had 65. And we are still combing through all the comments and questions posted then, and of course, anything posted on the website. But really, as a convener, how did you think that went? Maribeth?
Yeah, I'll just hop in and say, I mean, like you said, I think it was very well attended, and I think the conversations were really good. Even in the chat I was watching, and people were asking good questions and responding and bringing up, you know, things that they were concerned about, things that they wanted to know, and I think that that was a good opportunity for them to share those concerns and comments.
Thank you, Maribeth. And if you didn't get a chance to attend, we will do a quick kind of summary of some of the high-level questions and themes that we heard in the two working sessions that's coming up here, as well as we're going to share kind of a summary of the questions and our answers at that time. The team is, as I said, the team got a whole lot of content and feedback, and we are still coming through, but we will share that once we have it. Craig.
Yeah, so I listened as well, and I wasn't sure what to expect, but I was impressed by the amount of engagement. Just particularly the first session, I think, seemed like there was just a lot that people wanted to say and share. So I thought that was really good, and I just also want to commend Dan and Shannon on their facilitation of those meetings. I thought they did a great job with that. But I think it was helpful to have a forum for people to give examples of, there's a lot of anecdotal examples of things people have run into, and you know, I think it's really was useful in that respect.
Thank you. I know being in a virtual format, of course, has its own pros and cons. Pros, right? We got a lot of attendees because it was more convenient. Cons, of course, we had to manage a virtual environment, and communication, of course, of both verbal and nonverbal. So if you have any other suggestions for us, not just today, please do send it our way. And then I think I'll open it up for one more comment if somebody else has it. Thank you so much, Maribeth and Craig, for the feedback. That is definitely very positive feedback as we move forward with you know, more meetings throughout the year. Jim.
I was pleased, impressed that the people who were had oppositional questions, who were opposed or who were very respectful. It was somewhat different from past meetings where people would stand up and, not literally, of course, berate and not be particularly respectful in their questions or in their perspectives and point of view. I've thought everyone was very respectful and had thoughtful thoughtful questions, and were not, you know, casting aspersions on people's motives, things like that, because it was really big group, and in that forum, it would have been easy for somebody to rant, and I didn't see any of that. So I assumed the people who ran the meeting for us have a lot to be thankful for, and to be thanked for that.
Thank you very much, Jim. Okay, and I do think so. All good feedback and all great signs that it is definitely. We will definitely be figuring out how to continue the cadence of it. So please know we are not going to do anything during short sessions because there's just a lot of work during the short session. But after that, I do imagine that our first topic of Marketplace Community Conversations, probably in March or April, will be any work that the legislature asks us to do that comes out of the short session. And of course, I recognize as well that we have some departing members and incoming members. Again, these are all public meetings, so please know I will still invite you, and I will still ask you, hey, can you attend? So please look forward to more robust conversations throughout the year. And with that, we are switching over to work session mode. So the first one, so Jeremy and I, we would like to walk you through kind of some high-level thoughts on how we want to maybe potentially advance the mission for the state through the marketplace. The public option report, as you all know, that was required of us from the long session, and then we did submit, HPA submitted that report to the legislature on December 31st. While we don't officially have the green light for that, there was a lot of fantastic content out of that report, and we want to make sure that we are able to figure out how to make it work, whether it's through the public option or through another strategy. So Jeremy and Dawn, next slide, please.
So I'll kind of tee up this conversation. I think want to repeat Dan's comments at the beginning that there's a lot of sort of spinning plates here that we're trying to juggle. There was conversations have been going on for years of kind of future state of the marketplace and commercial insurance and finding more affordable options for folks and options that achieve a lot of our other goals. And so we're kind of piecing together multiple things here. On the public option, it's kind of where are we trying to be sort of longer term, and then want to transition to talking about a challenge that's right in front of us around redeterminations, and kind of want to tee up, I think, both in the context of what's been happening with health insurance coverage in the state. Last week, or maybe 2 weeks ago now, we just released publicly the latest health insurance survey data that we have. We do a sample survey about 8,000 households in the state every 2 years to understand what's happening with their health insurance coverage and where they're getting coverage and a variety of other issues in terms of costs and challenges around affordability and a bunch of demographic information. It's really our best read on what's happening. Even though it's a sample survey, it's still our best read and most accurate read of statewide where are people getting insurance. Important to note, though, it's also sort of a moment in time. So the survey was actually out in the field from January to September of last year. So recognize that these are still sort of mid pandemic or earlier pandemic numbers. The short of it is that the health insurance rate actually increased through the pandemic, and the rate of uninsurance, those who don't have insurance, decreased by about 1.4 percentage points, from 6% to 4.6%. You can see overall sort of what's been happening in the market. What's not on here is individual market and Medicare. Those have been flat, and they've really been flat since the launch of the Affordable Care Act. As we talked about, open enrollment numbers today, huge success and greatest numbers that we've had the last couple of years. But I'd say on the whole, when looking at the entire insurance picture, been relatively flat, been holding around that 140 to 145,000 folks in the marketplace. So aren't seeing a big movement of folks to the individual market. What we have seen is a steady decline of employer-sponsored coverage, which is what's called group here. And you can see there was a 2 percentage point reduction from 2019 to 2021. And the biggest area of growth has been in the Oregon Health Plan. And that's largely because of the issue that we're going to talk about later, which is that we not just Oregon, but nationally, all states have implemented a continuous enrollment policy through the pandemic, where we're largely not disenrolling folks. We are doing eligibility determinations where we can, but we're largely keeping folks in the Oregon Health Plan, even if they're sort of incomplete data. We've been allowing folks to self-attest to a lot of information, including income, and so you can see a really significant increase in Oregon Health Plan coverage. About 300,000 folks are on the Oregon Health Plan. And so that's some combination of who's on the Oregon Health Plan. We don't know exactly, but by taking this data and a few other data points we have, we can kind of back into knowing that there's obviously been some shift of folks who've been losing employer-sponsored coverage and have come into the Oregon Health Plan, and some of that might be that they were unemployed and have now picked up employment and may go back to that employer-sponsored coverage on the other end. But there's also a number of folks who were uninsured who've come into the Oregon Health Plan. We know that at least probably a fairly sizable number of those folks are folks who we call the churn population, folks who are going on and off of the Oregon Health Plan over the course of a year, either because their eligibility changes and their income went up a bit and they're slightly above or somewhere above the 138% of federal poverty level, which is the cutoff for the Oregon Health Plan, or because every time we go through the redeterminations process, which requires application back and forth and sometimes additional information or paperwork to be filled out, we know we just lose folks in that process. Address changes as part of it, or contact changes, and some of it's just confusion. Things happening, and a lot of things happening at once in a lot of these folks' lives. Some of these folks are going through multiple or sort of ongoing benefits redeterminations throughout the course of the year between not just Oregon Health Plan but other human services. To kind of tee that up, and I'll come back to when we get to redeterminations, what we have seen through this policy change that we've had through the pandemic, where we have not been disenrolling folks, we have seen that churn basically come to a stop. Before the pandemic, we had about 43% of the applicants in a given month had been on the Oregon Health Plan at some point in the last 2 years, and 25% in any given month had been on at some point in the last 6 months. That's basically dropped to single digits, and really the only folks that are applying right now have never been on the Oregon Health Plan or haven't been on in the last 2 years. So I think as we're thinking about both long-term and near-term challenges, I think we're trying to hold some of that information in our heads around folks who are sort of bouncing between uninsured and the Oregon Health Plan, and what that looks like on the other side of the pandemic. Chicky, I think, well, why don't we go to the next slide? As we get into the goals around the marketplace generally, I think there's been some common themes that we've heard from the community and also that we've been thinking about in terms of our broad transformation goals. One is really our goal around equity first and foremost. What wasn't on that last slide was that we know that there's not just 6% in 2019 and 4.6% today who are uninsured. We also know that when we look at those numbers by race and ethnicity, there's really significant inequities. In 2019, 12% of Hispanic Latinx individuals in the state were uninsured. We saw a small decrease in that through the pandemic. We know that in 2018, 8% of Black African American individuals in the state were uninsured. We saw a really significant reduction in that through the pandemic. Today it's 5%. So we're thinking about not just overall what's our, how would we get people covered, but also thinking about communities of color, other demographics, and folks who've been underserved or facing inequities, and how do we build to a better system that covers everybody with affordable, high quality care. We've also been spent a lot of time and have heard, I think, a lot of positive feedback around the importance of continuity of care. We've talked about continuity of coverage in the past, try to keep people insured, but I think a new dynamic of that, especially as we're moving into a world of really trying to cover everybody in the state, is how do we provide continuity of care? How do we preserve the provider relationship and the relationship between individuals in the health system as they're going through life events that maybe has them change insurance throughout that life event? We know that changing insurance can be hugely disruptive, but it's not just the act of changing insurance, it's the changing your provider, trying to figure out what drugs are covered, all of the things that go in behind that. I think we've also been considering principle around simplicity in the system, not just in the marketplace, but broadly. How do we make the system simpler and easier for patients to navigate, for providers to navigate, and what's the role of the marketplace or changes in the marketplace around that? And then finally, total cost of care. Obviously, this goes hand in hand with affordability and with covering folks. I don't have the latest numbers from the health insurance survey yet on people who delayed care due to cost. That's one of the things we measure, but we know that in 2019 it was about 12%. So 6% of the state was uninsured, but 12% said they weren't getting care because of cost. So you've got an underinsurance issue there, or it's still a challenge of folks being insured but unable to still access the system, and so wanting to make sure that we're keeping an eye on total cost of care. So those are some high-level principles that we've been thinking about, both in terms of the context of public option or sort of a longer term future state of the marketplace, as well as we're thinking about redeterminations and coming out of the public health emergency. Sharon, back to you.
Yeah, sounds great. Thank you so much, Jeremy. So that's a lot. That's a lot of content, and these are all fantastic guiding principles. I mean, we've heard it from the community, and of course, this is also through our work throughout the last few years within OHA and DCBS. So let me stop there first and ask, what do we think? What do we think about this? And this will also tee up the conversations and how, as we dive into the strategy, this is the overarching list of guiding principles for the marketplace to begin working on for the next. It's our guiding principles for the next 3 to 5 years. I think that's kind of it's a broad range, but there's of course there's strategies we can do in the short term and there's strategies that we can do in the long term. So that's my first question is to the committee. Any initial thoughts or feedback about the guiding principles? Craig, and then Mary Beth.
Yeah, thank you. I think the guiding principles are great. I don't have any particular comments. I think to simplify the marketplace, I'm curious whether that requires moving technology. Just if you want to comment on that.
It's possible, especially if that's one of the strategies this committee and the community recommends. It's definitely something we should look into. So I think that's part of the conversation. So what are the strategies that the committee will want to put forward to help simplify the marketplace? So I've written them down as a potential strategy for us to work on. Thanks, Craig. Mary Beth?
Yeah, I think that these guiding principles are really great in the fact that I think helping one of them also helps the others. So if we can improve continuity of care, we can also have an effect on health equity. And that can in turn help lower the total cost of care. So I think that they're really interconnected, and I think that these are good goals to strive towards.
Thank you, Mary Beth.
Okay. Any other committee? Oh, I was going to say I was going to share too if I could, but then also check. And anybody else want to share? This is a big piece of where we're going to be focusing over the next few years. So any other thoughts from committee members? Okay, I wonder how the work that the Universal Task Force for Universal Healthcare, fits into this, and if there's any, I don't know, crossover, especially under simplifying things. So obviously, I think a big issue is just how fragmented everything is and the large administrative burden that goes into managing it at the consumer level, the provider level, the carrier level, and everything in between. So
I might take a stab at that, Shannon. I mean, I think there's multiple conversations happening around kind of future state of the healthcare system that I think we're trying to keep connected. And I think the Universal Access Task Force is really thinking about the real long game here of really trying to build to more of what looks like more like a single payer system. And I think that's obviously not something that you can flip a switch on overnight. And so I think they're holding that vision of where do we ultimately, where does the state ultimately want to go, longer term. And I think a lot of these are more, incremental steps before that.
Thank you.
So thank you, everybody. So next slide, please. So as I mentioned previously, so we had our marketplace community conversation and public option and usability of plans. We also mentioned the guiding principles at those community conversations. And so this is just a kind of a high level look of the themes that we heard. So cost reduction policies beyond provider reimbursement rates. Public option is important to provide better behavioral health coverage. Affordability, still a big issue, monthly premiums and out-of-pocket costs. We were recommended to learn lessons from Colorado's waiver proposal. Again, also was mentioned, state-based technology is needed to enable innovation and fixing the family glitch still needed. So all of these are not, we're not going to be able to solve them overnight. As Jeremy mentioned, alluded to, there's a long game here as well. So just wanted to give you a quick look, a teaser of how those community conversations went. And I see a hand up before I move over. Andrew?
Cheeky, can you just, the family glitch, I attended some of the meetings, but I don't remember the definition of family glitch.
I think we lost Chicky.
She's having trouble. That's the situation where somebody who is offered spouse independent coverage through one of their family members is not eligible for the tax credits on the marketplace due to the marketplace only considering the price for the employee only insurance, not the cost to the spouse independents to get that coverage. Basically renders them ineligible for the tax credits through an unintentional mistake in how they wrote the law.
And Chicky got booted off. I know she'll be back here in a minute.
All right, well, we're waiting. Jeremy, anything you want to add, or committee members, any comments or reflections you have on the items that are up here? The meeting, like Chicky mentioned, was so well attended, and oh my gosh, so much great information. Mary Beth, go ahead.
Yeah, just on the family glitch, I had read something, I think, from the Commonwealth Fund about the Biden administration looking to try and address the family glitch in the next year or two, and I was just curious if there's any coordination being done with the federal administration on that.
Sarah?
We have, it's not a conversation that I've had with them. I don't know if the rest of the marketplace team, if you guys have had conversations with Society or others recently.
Any marketplace folks have any information on that?
Hi, this is Cable. I think due to part of the reason that the family glitch is in place, it actually has to do with IRS regs and rules related to the Affordable Care Act. So CMS and Socio have not directly addressed it in conversation because it's not inside the scope of the rules that they set, like the rules that Anthony was speaking about earlier, the benefit and payment parameters. So I think it's something we have to wait for the federal administration and the IRS to work through, whether that's legislatively or some other avenue.
Great, thank you.
Jim, I saw your hand up, but then I saw it go away, and I just want to check in. Do you have a comment?
I was only going to say what Cable said. There was tremendous. Back in the day, we had lots of conversations with the Obama administration about whether this could be corrected administratively, whether it needed to be done legislatively, because it's significant for lots of employees, families in certain situations. And I don't know whether the administration gave up or figured they did not have the heft to move it through the legislature in the second half of the Obama administration. But Cable pretty much covered it.
Thank you, Jim. Lindsay and Shauna, I just want to open it up. I haven't heard much from either of you. Do either of you ladies have anything you'd like to share or comment on?
Thanks for checking, Shannon. Nope, nothing I need to comment on.
Okay. And I think we have Chicky back.
Yes, you do. And my apologies, everyone. My area has been having both internet connectivity issues as well as obviously my phone, apparently my phone as well. So my apologies for missing any of those questions. I will catch up with my team for those questions and for any follow-up. So thank you for your patience. The beauty of virtual meetings is sometimes things are not in my control. So my apologies and thank you for your flexibility. Next slide, please. So one of the guiding principles, as we mentioned earlier, is to help us, the guiding principle is to focus on health equity And we've provided you here with a definition that the Oregon Health Authority is working under. It's actually a very long definition, and there's a variety of different content with the definition as well. But here's kind of a snapshot of that. And then next slide as well. And of course, with a focus on making sure that achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. Next slide, please. So here are some of the public option recommendations. Shannon, this is the start of the slide for work sessions, and hopefully to generate feedback from the committee. We have in front of you, they're all interconnected, but they could also be standalone. So please do think about public option as a tool. However, do you have any other suggestions on how we can go about this? So please throw at us any and all of your ideas. If you think it's too crazy, nothing is too crazy, we would love to hear all of your creative thoughts.
All right, Chiki, thank you. So we have some items up there that are recommendations that you already have. So any thoughts or comments on those, as well as any other ideas that we have under this lens, focus on health equity and public options. Any committee members have any thoughts? Craig and then Jim.
Yeah, it seemed like when the meeting happened last week, I think this is where I heard this, or maybe I'm thinking about internal discussions at MONA, but access to certain types of providers seems like it's an important consideration for health equity. At least that's the kinds of conversations, and I don't know if that's covered in any of these bullet points here.
Thank you, Craig. Jim?
I have an equity consideration that is not typically included in exactly in healthcare, but it does come up because of an event that happened recently with one of our favorite carrier or provider delivery models with Kaiser, with an effort, at least as reported in the media, to lower the pay of incoming staff that are covered by a union in this case, but many provider staff don't have unions to, and certainly the union doesn't need our help. But when we're talking about the various carriers, providers becoming more efficient, cutting costs, which are going to be almost built into lowering premiums and improving care, we want to be sure that the result of that is not that the people at the bottom in the carrier provider community are the ones that bear the brunt of this, these cost savings. And I don't, I mean, I'm sincere when I say that Kaiser is my preferred model for provider business model, but so I don't, not at all picking on them, but what we don't get to hear about what happens at other healthcare providers and carriers where they're going to be cutting costs. But we want to be sure that we watch out for that potential as an equity issue. So.
Yeah, thank you for that, Jim. I know through the Cost Growth Target Committee, monitoring for unintended consequences is something that's on the radar, and it's things just like that that we have to make sure we're keeping an eye on as healthcare evolves in our state.
Exactly.
Other committee members have any input or other ideas for this slide? All right, I was going to say, I'll add in this network access, is really huge. And from rural Oregon, sometimes disproportionately affects us out here. So that's something that's extremely important as we're looking at new plans for the new year. Andrew.
Hi. One of the big issues about equity potentially is just simply the supply of kinds of providers and sufficient providers. And then not really sure if this committee and work group can even address supply, but I think our plans ought to be thinking about how can we improve supply and get creative about redistribution is just the wrong word, but how do we take better advantage of technology so that rural Oregonians can access the same kind of supply available in metropolis Oregon?
Mm-hmm. Thank you for that, Andrew. And piggybacking on Craig's comment too, really making sure that certain providers are looked at and made available. Lindsay.
Thanks. My thought goes around people who have English as a second language and providing, I know this is like very standard equity work that's probably included in this already. And I just know that so many of our clients who don't speak English as their first language struggle extra hard to understand what their benefits are, understand their networks, and continue to have access to services regardless of what the benefits are and what the changes are.
Yeah, thank you for that, Lindsay. I agree and echo that. And really, from carrier to carrier, there doesn't seem to be consistency with how available information is in secondary languages. If that's just ready or it has to be ordered, it might take a few months. So that's a really critical point to bring up too. Any other committee members want to share? Sean, Shauna? Hi, Beth. All right. Well, Chicky, do we have more on this topic, or would we be switching over to the Medicaid migration?
We still have more, so next slide,
Excellent.
Please. So with this slide, it was recommended to encourage consumers to report race and ethnicity information during the application process. Currently, a significant number of enrollees do not report. These fields are usually, majority of them are not. These are optional fields, and CMS is considering requiring carriers to collect this information separately from the healthcare.gov application. So we would love your thoughts on these, please.
Mary Beth, go ahead.
I'd just be curious, like how we would be collecting that separately from the application, because I do think that could be a burden on both carriers and consumers to actually like report that and go through another process apart from just the application for their health coverage.
Yeah, thank you, Mary Beth. And I don't know if that's a question that anybody on the line could answer, or more comment that it maybe feedback to CMS for marketplace staff who comment on these items. I saw Gladys with her hand up.
Thank you. I'm an insurance broker, so I'm the one helping a lot of my clients, and it's usually the question is why they need to report it. So a lot of my clients are not comfortable reporting it because they don't know how the information is going to be used. And so if they're not comfortable, even with group insurance, they have that form also when I'm helping them with enrollments through their, and they don't want to really report that. Whether, it doesn't matter their race. I have those that are Spanish speaking, Hispanic, then I have my Russians, and then I got my English speaking Caucasians, and a lot of them just really don't. So I think to have additional requirements separately, they're probably going to get less information than they would going through the process, because that's going to take time.
Yeah, thank you, Gladys. Sean, I think I saw your hand up next.
There we go. Yeah, I'm just curious what that outgoing call system is going to look like. If it's just going to be a call from the carrier asking someone's race and ethnicity, that seems like it runs a significant chance of creating some worries, especially for clients that are concerned about public charge and things like that. That would really have to be done well somehow to make that whole data collection pass work and get people to respond to it in a greater number than do in the application. I also wonder if we have data on how many of those folks that aren't responding are coming through community partners. I know both just for speed angle and for the question gets uncomfortable, sometimes that's community partners are going to be skipping that one. I have noticed there is a bit of a pattern of asking folks what their race or ethnicity is, sometimes gets racially insensitive responses is the kindest way to phrase it. You get a lot of interesting answers from people sometimes, and most every one of my employees has been person of color, and that's usually who we have asking these questions, and it's an uncomfortable point sometimes, and that's also sometimes where we get the non-answers from.
Thank you, Sean, for sharing that. Andrew.
Thank you. Not knowing 100% about the CMS requirement, one thing that, or one approach to collecting some of this information, at least for carriers that are somewhat integrated with providers, is to actually collect the information from the provider side, which is one of the things that I know some carriers are doing. I'm also not an expert on interoperability, but I think interoperability provides another opportunity to improve the sources for where we collect, carriers would be collecting information. I think that's possible to collect that. Again, improves the chances of a carrier being able to collect this information from a provider. So again, I'm not enough expert there, but it might be worth additional exploration.
Thank you, Andrew.
Most providers, or at least qualified health centers, are required to collect that data now. We have it in Epic. It is pretty easy to pass data out from that, and that seems like it's a much more less intimidating way of approaching it, rather than a separate call from the insurance company and somebody worrying, why is this person calling me asking only about my race? And
right. And speaking just for one carrier, I would agree with that. Is we consider that a more primary source than other sources.
Thank you. Great conversation. Thank you, everybody, for your input. Chicky, do we?
And I think we have plenty more.
Excellent.
So next slide, please. So other strategies, options for marketplace plans to focus on health equity, adopt CCO metrics on translation services at the provider level, increase access to culturally appropriate care via telehealth, and broader coordination with essential community providers or ECPs.
All right, same format here. Any committee members have any comments or feedback on these? And then we'll open it up from there. Gladys.
So question on this one. So is it just collecting the data as to how many individuals have requested translation services when they're scheduling an appointment? Is that what that is?
No, I don't believe. Are you referring to the first bullet, Gladys?
The first bullet, yeah.
So it's really looking at what requirements and metrics have been asked of CCOs regarding translation services at their provider level, and seeing if we can ask our marketplace plans to do the same.
Got it. I think that would be very important to do, because even when when I'm helping somebody enroll, their concern is, how can I find a mainly Spanish-speaking provider? And it's like, well, you have to call and ask. With Kaiser, it's very easy. When they make their appointment, they can ask for that translator immediately. But all the other carriers, it's at the provider level, which makes it a little bit more difficult, because they may or may not have somebody for them that can translate. So I think this is something that is so important to have for those consumers that have that need for translation services. It's hard enough for them to talk to their provider about their health and maybe some embarrassing things in sharing, and then now the provider doesn't speak their language. So I think this is something that's very, very important.
Thank you, Gladys. Any other comments on this one? Welcome.
Hi, I agree with Gladys because I work on the community that they don't speak English as a first language, and some of them don't speak it. On the translation service, I thought it's part of human right that they can require for translation or interpreter, but the quality of those people are not good. And if we can have, to improve or focus on health equity, have some kind of metrics to make the standard, or get the people who become a translator or interpreter have some qualified, that would be really great, and that will help everyone to be on the happy side. Thank you.
Thank you for those comments. And great, thank you, ladies, both for sharing what's happening, on the ground, what you're seeing with the clients that you work with and advocate for. Okay. All right. So we're kind of a quiet bunch today. We have a lot of slides to get through, so let's keep them going. Chicky.
All right, thank you. So again, also under the focus on health equity umbrella, CTO levers to address social determinants of health. The original CTO vision in 2011 was to improve member health by comprehensively supporting their needs via both medical care and SEOH. While notable progress is made for the second CTO contract in 2020, Oregon's governor requested enhanced contractual requirements for SEOH and health equity. And in full disclosure, I do not know all of the specifics of SEOH and of those contracts, but I believe either Jeremy or Tim can speak to it if you have questions about it at a high level. But if you do know about it and you have initial feedback, we would love to hear it at this point.
Thank you, Chicky. Any comments on that? Social determinants of health, such a critical part of overall health and outcomes for consumers and clients. It's great to see some more focus on those items, as we see so often, just how critical they are to overall health. Any comments or questions?
And actually, Shannon, the next slide has some levers.
Great.
That we can think through. So I don't know, I believe has her hand up. I don't know if it's for this question or the last, but it's also entirely possible that a lot of these require a lot more time and thinking and research beyond our time, our shorter work session today. So and for us, if you don't have any initial feedback, that's completely fine, and we'll come back hopefully with additional information or follow up with you directly. But I also see Craig's hand is up. Craig?
Yeah. So I guess my reaction to this is if a marketplace plan is being administered by an entity that's also a CCO, it seems like some of these requirements are natural. If we're working with a marketplace plan that maybe has no background with a CCO organization, they'd have to build out these services. So I'm just trying to think that through, whether the Oregon Health Authority wants to have consistency between CCOs and all marketplace plans, or it's going to be maybe just the public option. Yeah, I'm just trying to think through how that would all work. I mean, I think they're all good components around social determinants of health, but it's just on a practical basis. it's going to take some organizations a bigger lift than others to meet these.
Thank you, Craig. Say any other comments? And to say this too, I just want to say how quick of a turnaround time we've had on all of this. Those community meetings, like Chicky mentioned, were just last week, and it feels like it was a month ago, but it was just last week. So many moving parts to this work, as well as just things in our personal lives right now too. So things are busy. So I appreciate everybody's willingness to share and comment.
Okay, so I think we're ready to move on to the next slide and a different guiding principle. So heading over to improving continuity of care. So the public option report, some of the recommendations include incorporating CTO networks as much as possible, expanding the use of traditional health workers, funding services to address social determinants of health. So some common themes, as you probably already noted, but initial thoughts and feedbacks and suggestions are welcome.
Mary Beth.
Yeah, I think that the first bullet point especially will help just overall, as we look at the Medicaid churn population, as we look at the redetermination process, I think that if we could align those networks as much as possible, I think that there would be a lot of benefits both for consumers, but also for providers and OHA as we work through these processes. So I really appreciate that first bullet point.
Thank you for that. Lindsay.
I really like all three of these, and I want to echo Mary Beth, and also think expanding in THWs and working on services stress social determinants, like that sounds like it will all, all of those things will work together really well to support continuity of care and to support improve health outcomes. I mean, I think all of these bullet points are fantastic.
Thank you. All right. So I think we have a couple more slides on this particular topic, the improving continuity of care.
So expanding the essential community provider requirements, currently carriers are required to cover 20% of available ECPs in their networks or explain why they do not meet the standard. Also comparing providers on the traditional health worker registry to the ECP list may highlight deficiencies that could be addressed using the ECP requirements. So Katie, I'm actually going to call on you to see if you have any additional information or context you want to provide for these.
Sure. So hi, everyone. I'm Katie Button. I'm the plan management analyst. So one of the things that I monitor is whether carriers are meeting this ECP requirement. And it's always just been kind of a, do you do it? Great. And there's like a tool and everybody meets it. But I would love to make it something more meaningful. And so I really think that, seeing which THWs are on the list and asking carriers, and then I can look and see, do you contract with them? And then, go to the carriers and say, hey, why not? Is there like a thing? Can we help you work it out? And then also seeing if there are THWs who aren't on the list who would like to be on the list and helping them get on the list. And we've done that with some other types of providers in the past, which has enabled them to then be able to take marketplace coverage and stuff like that. So that's kind of what I'm thinking. And Holly had actually suggested that at one of the conversations last week. And I was like, yay, I love it when other people have the same idea as me. So I would love any feedback that you have on that idea.
Thank you, Katie. And yet network access is so critical. I'll share with my agent hat on that we've seen a little bit of a difference in how people are contracted. So we've seen some carriers contract at the facility level and some contract at the provider level, which has led to so much confusion for consumers using the search tool to find out, are they or aren't they a network? And then when you add in that what was Oregon legislation, but now federal legislation, that if the facility's contracted, all providers are, right? But unless you really delve deep into health policy, you don't know that. So from a on the ground consumer perspective, it can be really hard to know what's really going on when there's differences. Any other comments on this topic from anyone? Craig?
Yeah, so I'm thinking about, so continuity of care, I assume means continuity when people move between Medicaid and commercial. Is that the continuity we're trying to maintain? I think that's, well, using that, I'm going to assume that. So I think one thing we want to think through is the individual market. I think particularly in Portland, I'll use that as an example, is getting to be very centered on narrower networks. Maybe that's not the right term. Maybe I'll call them high value networks that are integrated with a delivery system. And that's by design to try to keep care coordinated effectively. And people have choices. They can pick a Kaiser plan or one that features Providence or Legacy, that kind of thing. So I think we just have to be thoughtful about when we add requirements for additional providers, that it makes sense with the delivery system that's underlying that individual marketplace plan.
Thank you, Craig. So I'm going to say I saw Mary Beth's hand up, and then we'll move to Sean.
Yeah, just on Craig's comment about kind of what type of continuity of care we're looking at, I think it's also important to have that as people change from marketplace plans. I know people who have changed from silver to bronze plans or bronze to silver plans and had to change carriers because the plan that they wanted wasn't available at a different tier. So I think that continuity of care, even within the marketplace plans, is important as well.
Yeah, thank you, Mary Beth. Sean?
Yeah, there are some other things we can do to support folks who are transitioning from marketplace to uninsured status, or who aren't going to qualify for marketplace coverage for a bit and go uninsured and other things. The main thing that comes to mind is to get the community partners we have across the state kind of filling out or referring to sliding scale programs and hospital financial assistance. It makes a real big difference in the patient's experience of that application process. If they're when you get denied from the marketplace, you're immediately rerouting to sliding scale programs and hospital financial assistance and getting them some access to the care they need in the meantime. Just blunting that impact of their first experience with the marketplace being a really negative denial experience makes a big difference in their likelihood to come back to you later and reapply for that. So just including that kind of as the standard toolkit is OHP, marketplace, and then the charity care programs, the financial assistance and Oregon's hospital financial assistance mandate. Anyone below 200% of the poverty level has a pretty good swath of access to services that the community partners are really positioned to help connect people with. It's very locally specific resources, but those community partners are a good resource to be able to do that, and we can do a little bit more with them if we kind of broaden out their role. It also equips them for those really tough conversations, which denials of coverage are the worst thing to go through in this job. Having that conversation with people is just not pleasant for the assister as well, and we don't really prepare folks for that conversation as part of our trainings. Putting those two tools in there really serves the patient a lot better, but also just makes it a more pleasant experience for the marketplace, that if their first experience is going to be a denial, or marketplace or OHP, either way. Also, just it's good to view them as a member in the future or something like that, because they're likely to, a lot of this trend population will end up coming back to us whether or not they qualify now. So
yeah, thank you, Sean, and thank you for your work too, making sure clients have access to what they need, and yeah, as those churn populations evolve and just different points in time with different consumers, you never know what kind of insurance you're going to need. So thank you. Andrew.
Yeah, thank you. With respect to how the marketplace potentially makes more availability, greater numbers of traditional health workers, one thing that's crossed my mind is at least the perception of quality differences, quality of care differences that might be delivered. I've been part of dialogue in various settings where perhaps traditional health workers aren't getting to screenings the same way that maybe traditional, like an internist might, or people, or the more I was about to say traditional worker, but we're using the word traditional twice here. And so I would imagine, I think it is important. It's definitely going to be helpful in maintaining both high access as well as affordability, but addressing quality concerns might ease our way with respect to increasing adoption or lowering barriers, so that we're not simply adding not traditional health workers at the cost of high quality care.
All right, thank you for that. All right, I think we have one more slide on this particular topic and then a few more to round out this particular section.
So expanding essential community provider requirements, as same theme with the THWs, encouraging them to apply for inclusion in the ECP list increases the likelihood carriers will contract with them. And Marketplace can serve as a liaison to connect THWs and carriers for contracting. So I believe this is Katie volunteering to be the liaison. And I am smiling because she is always coming up with all of these creative ideas and coming to me. So what do we think of these ideas?
It seems like a positive change, though even with the expansion of OHP coverage to allow patient support services billed for community health workers and whatnot, our community health worker program has not been utilizing it at all because it's a bit too administratively complicated as opposed to using other funding sources. Just creating that option won't necessarily result in uptake on it is the one thing I've learned from that portion of it.
Thank you, Sean. Any other feedback or comments on this? You know, community health workers or traditional health workers are so important, and as I'm sure we've all seen, change the outcome of clients' healthcare so much too. It's great to see a focus on this.
Well, I'm sorry for my questions because I just need some clarification on why traditional healthcare worker is not in the ECP. Is that because they don't get paid enough, or can someone just help me with that to help me understand? But I see the change that just like Sean said, is positive.
So I can take that question. So they might be on the ECP list already. I've been struggling to get the list just because there's a pandemic going on and the poor staff are super overworked. So I'm hoping that when I get the list that there will actually be a fair amount of overlap. I just don't know. And so I'm just kind of really in fact finding mode. And so then depending on if there isn't a lot of overlap, then maybe we start to do some outreach because some folks just don't know that there is an ECP list and that they can apply for it. And so then carriers don't know too that those folks are interested in contracting. So this is really, again, just kind of like the starting point to try to see where we really are and where we could get to.
Thank you.
Yeah, thank you, Katie.
Thank you for the feedback. So I think we will continue moving forward with these strategies. We have enough information to get us going. Thank you. So moving over to the next principle, help lower the total cost of care. Of course, with strategies as recommended by the Public Option Report, utilizing Marketplace to take advantage of the federal funds. Consider 1332 waiver options to reduce premiums and reinvest federal pass-through funds, and prioritize additional funds to increase plan generosity and provide dental coverage.
Mary Beth.
Yeah, I just remember reading about this in the report and the recommendations in it, and I just really appreciated the fact that the numbers were kind of crunched with a bunch of different options of what could be covered by this waiver and the funds that we could get from it. And I think utilizing those funds in a way to help lower the total cost of care is going to be really important. So I think all three of these are great, and I really hope that those are enacted.
Thank you for that. I see your hand up. Did you have another comment?
Nope, sorry.
Okay. Oh, no problem. Jim.
Yeah, I agree with Mary Beth. These are critical opportunities, and we're always looking for opportunities in a program like the marketplace, and these look like to be just that. And so we should take full advantage.
Thank you, Jim.
Do we have more details on what we're referring to by taking advantage of federal funds?
So I can take this, and then Tim, if you're on, or Jeremy, if you have additional information for this. So taking advantage of federal funds, for this one, primarily we're talking about, of course, advanced premium tax credits and cost sharing reductions. Where can we, that as we all know, is one of the major incentives for coming onto the marketplace and figuring out strategies for where we can really stretch those tax credits and cost sharing reductions. Tim or Jeremy, do you have any additional information for this?
Yeah, I had a couple of things. So Colorado submitted a public option waiver request, 1332 waiver request, which has not been approved yet. But their general principle is they've set 5, 10, 15% premium reduction targets. And their pitch to the federal government is that any given year, the difference between what premiums would have been and the reduction due to those targets, that they'd be able to capture those dollars and be able to plow them into further cost sharing reductions. So somewhat thinking about how the reinsurance waiver works in terms of sort of capturing the difference between what premiums would have been and what they are. So that hasn't been approved yet, but the idea would be if you could come up with a mechanism to somehow, bend the cost curve and capture the difference and be able to put those back into cost sharing reductions as a way to reduce costs. I will note that one challenge with 1332 waivers that's different than we have in Medicaid with 1115 waivers is they have a very different sort of budget neutrality calculation. They look at individual years, not sort of over the course of time, and they have a sort of deficit neutrality, not just a budget neutrality. So if you do things that increase enrollment, they sort of count that against you. And so there's some challenges there, but Colorado thinks that they've been able to propose something that still allows them to, in a single year, if they can calculate the difference of what premiums would have been and what they are, sort of capture that savings and in essence, reduce cost sharing as a result.
One other thing I might want to add to that topic then would be just increasing promoting the existence of programs like Lindsay's would also be helpful to get more federal funds coming into the marketplace, and that effectively helps the hospital financial assistance programs take advantage of those federal funds. That's about a 2-to-1 return for them. Washington has that state sponsorship system where they provide some framework to those programs to help them get started up and whatnot, and kind of certify them with the exchange. Something along those lines might be another way to help increase that on the increments, or on the margins or something, and get a few thousand more people covered and taking advantage of tax credits across the state. It'd have to be regionally done one hospital service area at a time, but.
Yeah, thank you, Sean. Craig.
Are there more slides on this topic?
I think we have one more.
Yes, there are.
Well, barring that I might get ahead of myself on a couple comments. I think this title is a little bit of a misnomer. What is on this slide is more how you increase revenue, not necessarily how we're addressing the total cost of care. That feels more like the work that's being done in the sustainable healthcare cost growth target. Maybe the exception to that is the 1332 waiver, where you have to achieve certain cost targets to get the waiver money. But I just wanted to comment on that. And then this is a little bit in the weeds, but when I read the public option implementation report, the thing I couldn't quite understand, it seemed like the numbers that were in there assumed that the entire marketplace would hit certain cost growth targets to get the funding. But it wasn't clear to me that the entire marketplace would be public option plans. Probably not explaining that very well, but they're trying to think how to put this. I'm kind of going down.
I think
Yeah, go
Yeah,
ahead.
Craig, I think you know where you're headed. The overall modeling is if you hit, and Tim, correct me if you're on and I have this wrong, but the projection I think in Colorado and the modeling that Manat had done was basically if you hit those premium reductions of 5, 10, 15%, the market's in essence going to move that way because it's so much more financially advantageous for members to get there. So it's not a replacement of all the plans, but it was in essence that every carrier would offer this design public option and the market would eventually move there and you'd sort of capture savings across the market. I believe is how it's modeled. Tim, let me know if I've got that wrong.
No, that's right. It is the public option plans that have to achieve those premium reductions, but the impact is big because more people choose those plans.
Okay, that's great clarification. Thank you for that.
So actually, Craig, your question is a great segue to the next slide. Still under the principle of helping lower the total cost of care. So some other public option report recommendations. So consider how to align plan design and oversight with cost growth target program. And then aligning value-based payment efforts across markets. So we're thinking OHP, PEB, and OWEB, and commercial.
Jim.
Well, this is where I think what I envision the public option insurance plan to kind of fit in best in terms of understanding. And my understanding comes from, for example, some of the questions or concerns that were voiced when we had the public meeting about shifting that it was either carriers, providers being concerned about shifting the costs from if we lower the premiums in the low wage sector that we would be aiming for in public option, that they're going to go up somewhere else. And the thing, I think the reality is that, and what I've learned through the last 10, 11, 12 years is that the costs have already been shifted. I mean, small business insurance is somewhere like 18% more expensive for the same plans as big businesses. And actually, I looked that up today, and the most recent figures I can find is 2018. I don't know how that might have been changed since then, but it seems to me what we're looking to do is build a larger buying group, and enabling that the public option enables negotiations closer to what the large employers, large businesses are already able to do. And what we're doing is leveling the playing field more than disadvantaging someone or some large company who's got a lower rate than what we're able to do at this level. So in addition to the federal funds, which are going to be absolutely essential, those sorts of things, by building a larger buying group that's both able to share costs more readily, but also to negotiate better, shouldn't be dismissed as a real advantage of something like a public option that can join with OWEB and PEB and OHP and the the other purchasers. So,
thank you, Jim. Andrew.
Thanks again. One topic that has been on my mind with respect to cost control is actually something I'm struggling with. If the public option, or I'm trying to get my head around the dynamic of, will the public option draw away more individuals in the current individual marketplace who are getting federal subsidies. In other words, they have less moral hazard than the current marketplace, leaving what's the non-public option portion of the individual market, in essence, more expensive, in essence, something that would look like a higher statewide morbidity, perhaps accelerating, a death spiral, or creating something like a unfavorable underwriting spiral for the non-public option part of the individual market. That's not addressed in the paper, but I think it is an important consideration, because I think that's a real dynamic that that could be the intention of what we want to do. But I think it ought to be explicit and clear about what might happen to the rest of the individual market.
All right, thank you for that, Andrew. Mary Beth?
Yeah, on the second point related to the cost growth target, I think that the cost growth target has been doing a lot of great prep work over the past 2 years or so to get this program ready. And I think anything new that's going to be on the marketplace has a unique opportunity to really start with this cost growth target and align itself with the regulations provided by it. So I think that this is a really unique opportunity to have a product that doesn't have a past in essence, and to have kind of a model to follow on how to comply with the cost growth target. So I think this is a really interesting and unique opportunity.
Yeah, thank you, Mary Beth. And it's a great observation on the positives that are coming ahead of us. Dan.
Thank you, Shannon. Thanks for letting me jump in here. And I just want to build on Andrew's comment. I think that was a really good insight and something that I would suggest the Marketplace Advisory Committee needs to pay special attention to, which is the impact of this on sort of what I will call adjacent populations or adjacent programs, including the core marketplace programs. That hasn't been extensively vetted from what I can tell by MNAT or OHA. And it absolutely has to before this gets through the legislative process. So really looking to understand how does this impact 150,000 Oregonians currently on marketplace coverage. And I think one of the great things about Oregon and OHA, and Jeremy and Tim epitomize this, is we are taking a holistic look and we're not sacrificing one market segment for the other. We think about the shift to the employer market. We've talked about that, small business costs. Jim mentioned that. We think about, even though we're in the marketplace, we think about how do we protect people coming off of Medicaid, which is an entirely different state program. We even talked this morning with Stephanie about Medicare and other issues. So I just want to acknowledge there are a lot of hydraulics across programs here that we absolutely have to completely understand so we don't make a misstep in service of one goal, which is to protect people coming off of Medicaid, and unintentionally impact the risk pool and the cost of care in the marketplace. So I don't expect anybody to respond to that, but I think that's the one of the really great things that this advisory committee can add to the discussion. So I appreciate Andrew and others focusing on the interplay between different programs.
Thank you, Dan. So we have Andrew and then Sean.
Dan, you said you didn't expect anyone to address it, but I'll also offer. So one of our principles was to root our conversation in fact, and so the OHA has seen about a 7%, or at least the Portland market of OHP has seen about a 7% decline in morbidity as a result of, in essence, suspending redeterminations. And the statewide market, individual market morbidity has grown about a similar amount, slightly more for potentially for other reasons. And so without the public option, we were, and with the beginning of redeterminations, I would expect many carriers would in fact do premium reductions or something along those lines to reflect the declining statewide morbidity. That's part's not obviously not fact, that's opinion, but as many of those lives that move from Medicaid back into the individual market, the individual market itself will become cheaper once again. That should be a reasonable expectation, put it that way.
Thank you, Andrew. Sean.
Just, it seemed like a lot of this conversation that the providers were having about reimbursement rates is kind of dancing around Medicaid discrimination to a degree. At least currently, some of the reason behind why folks feel they receive worse service on OHP is because the providers receive less money for that. So I think there's a combination of that worry that they're creating another kind of Medicaid discrimination situation unless the public option manages to be so successful it rapidly achieves market dominance. But also there's a little bit of an aspect of kind of what Jim was bringing up later with Kaiser cutting its wages. If there are cost cuts being put on to the insurer, making sure that those aren't directly put over to the provider's cost and slashing their wages and the care provided to people. So there's a few concerns weighing around there, but one of the things they wanted to avoid was creating another situation where folks get worse service on these public option plans compared to the private market ones. The issue is in the conversation there.
Thank you, Sean. I'm going to say, I think that was our last slide for this particular topic. Are there any final comments that anyone has? And then I'll also ask Chicky if you felt that we got what we came in to get out of this conversation.
So I will take that last question first. I think yes and more. So I've been furiously trying to keep up with my notes, and then of course my brain is churning with different thoughts and ideas. All great feedback. I'm looking forward to actually diving into these topics, hopefully one by one or one by two in these community conversations. So thank you so much for the initial feedback, and we will definitely be in touch offline and through community conversations to dive into the weeds a little bit more. So thank you.
Awesome. Any final comments from any committee members on this topic before we take a deep breath and exhale and transition to our next work session, which is also, really great in depth, and I'm sure a lot of comments will be made. No, all right.
Okay, so we are heading into the work session for Medicaid redeterminations and of the PHC continuous coverage requirements. So I will actually, Jeremy will take the first set of slides, and then I will follow up, and then Katie will take us down into the discussion section.
Great. Thanks, Chicky. So the last few comments on the last slide, I think, are a very good segue as we move into the redeterminations issue. So a little bit of background here, and then we'll get into the current plan. And I'll say current plan because this is in flight. And again, back to Dan's comments at the very beginning, we have been trying to build out a plan with one hand tied behind our backs, essentially because the federal government's dictating a lot of the timeline. We don't know when exactly the public health emergency is going to end. They've provided some great guidance, but we just had our first conversation yesterday with them, and I will say it was a great conversation, and I'm feeling a lot of partnership and flexibility from them. But at the same time, there's a lot of unknowns for states as we're all trying to grapple with how we're actually going to do this, and then the fact that we have one 35-day legislative session that begins next week, while still with a bunch of unknowns, and that likely this process has to begin before we have another legislative session, which I think is a very challenging situation for how big of an issue that we have in front of us. So all that to say, I think there's a lot of questions out there, and we will be beginning. This is one of many conversations that we're having, just in the last couple of weeks, and we'll be having many more conversations with stakeholders over the coming months. But unfortunately, also have a situation where we've got a legislative session that we're trying to figure out what, if anything, we need out of it at the same time. The overall kind of issue here was that I think for a lot of very good reasons. We basically, as a nation, enacted a continuous Medicaid eligibility policy during the pandemic so that we would keep as many people insured as we were going into the COVID response as possible. Functionally how that happened was Congress in one of the very early COVID relief bills gave states a 6.2% enhanced federal match. In essence, they paid states to keep people on, and in exchange for them enacting this policy and not disenrolling folks during the public health emergency. The public health emergency has been extended in basically 90-day increments multiple times since it was first passed. It was slated to expire in January 16th, 2 days before. They extended it till April 19th. There's all sorts of rumors out there that it could be extended again. I think it's unlikely that we'll know if or when that happens until probably days before, just like we did this time. It's sort of a double-edged sword. I think for a lot of states, we're all looking for predictability, but we're also looking for more time. So I don't think we want less time in exchange for predictability, but at the same time, we're really struggling with trying to plan when we don't know exactly what the timeline is going to be. So we're in essence building a plan that is flexible and can shift, and we'll have to see how things unfold throughout the year. As a result of not of keeping people enrolled for the most part, with some exceptions that include death, or if somebody moves out of state, becomes incarcerated, or voluntarily leaves. Those are sort of the times that people are exiting. And most people have stayed on, and what we've seen is a 27% increase in a caseload. We've grown from just over 1 million to or just under 1.1 million to just under 1.4 million during this time. Our forecasting team is expecting that over the course of going back to business as usual, about 300,000 people will come off of the Oregon Health Plan. Why don't we go to the next slide? So you can see the jump here. Recognize the bottom line here starting at 1 million. So this is a little skewed, but you can see the steady growth that we've had over the course of the pandemic. It's been pretty much consistent month by month. Our forecasting team, as I mentioned, is expecting about 300,000 people will come off the Oregon Health Plan as we go back into the normal eligibility redetermination and disenrollment process. We will have about a year to do that process, meaning if you sort of spread that out evenly over the year, you could expect that, on average, unless we stat the deck differently, on average, we'd have about 25,000 people a month rolling off of the Oregon Health Plan. I just want to stop there for a second, because I don't know that folks have really wrapped their head around what that's going to look like. The last time that we've had a major backlog and had a major disenrollment was in 2017. That was sort of some fallout from moving from a paper application process into the one system, and still getting caught up on things that happened with Cover Oregon. There was about 50,000 people that were disenrolled over the course of the year that it took to get caught up on that, roughly. And there was really significant. It really dramatically changed the capitation rates for CCOs. There was a really significant increase in risk scores. So in essence, what we did was disenroll a lot of healthy people and keep a lot of folks who had more chronic health conditions in. We saw really significant increase in payments to CCOs as a result. And that was 1/6 of what we're going to see over the course of this next year. So this is going to be a really significant thing that, as a state, we're all going to have to go through, and we're not alone. Every state's grappling with this.
Jeremy, I want to jump in. Sean raised his hand.
Yeah, just a quick one. Do we know if the folks who have reported an income change that they are already over income and have recently already redetermined or something are going to go through the same redetermination process before termination?
Yeah, thanks, Sean. So we've, if people say they're over income, Chicky, I should apologize. Our Medicaid team wanted to be here today and had some conflicts and weren't able to be here. But we're recording this and shepherding some information back to them. If people are self-reporting that they're above income, I'm not sure if we're disenrolling them or not. I think we probably are, but Chicky, do you know the answer to that? But I can get to the second part of that.
Yes, so if they are self-reporting and doing the disenrollment themselves, and yes, it is the automatic termination of those that are no longer eligible. That's the requirement that hasn't happened. So if the person is the one doing the self-reporting and terminating, then yes, they are coming off of OHP.
Yeah, that's so. If someone reports that they're earning, say, 10 grand a year as a single, 10 grand a month as a single filer right now, is way over income. is that person going to go through the same redetermination process as everyone else, like through this long cycle of metering the redeterminations, or are their benefits just going to cut off as soon as the?
No, we have to, under federal guidance, we have to do a new redetermination for every single person on there.
Okay.
So the purpose of that is to not use outdated information. So recognizing people may have gone up and down throughout the course of the pandemic, they may be unemployed or reemployed. So the federal government has put out guidance very specifically aimed at not having states automatically just kick a whole bunch of people off based on outdated information. And so we will have to go through the normal redetermination process for all 1.4 million folks and make a decision based off of new information. Now, a lot of that's through an automated process where we get information, but we still will have to, we'll look at everybody with new information.
Lindsay, oh, excuse me. Sorry, I was going to say Lindsay had her hand up too.
Thanks. I'm curious because I know that there are some people who actually want to come off of OHP, and I'm wondering if for those people who want to come off and who are over income, if they would be able to skip the kind of like regular cycle redetermination process and get off sooner.
People can disenroll at any time that they want. So there's nothing prohibiting somebody from disenrolling today if they don't want to be on the Oregon Health Plan or know that they're no longer eligible. So that's come up a bit in the last week. I'm not exactly sure where the confusion is there because we're not prohibiting people from leaving. What we aren't doing is involuntarily disenrolling them.
Yeah, it just prohibits people from qualifying for tax credits on the marketplace when they opt out on their own. So they would need that.
And so one thing that we've been trying to think through as we're staging the 12 months, and I'll get into this in a second here. You know, our plan is to sort of our current default plan is to sort of spread all these redeterminations out evenly over the course of a 12-month period. We've been, when I sort of mentioned sort of stacking the deck, we've been trying to figure out, do we just haphazardly do that, you know, and randomly pick people for a month, or is there some other prioritization? Are there folks that we know, you know, want to come off sooner that we would start with, or, you know, or vice versa? Would we want to start with folks that we have complete information for and push some of the folks that we have incomplete push information for towards the back of the line so we have more time for outreach and enrollment? Those are some of the things that we've been kicking around.
I see one more hand up, Gladys, and then we'll kind of get through the slides because I'm sure there's a lot more great information coming up. Gladys, go ahead.
So from an agent standpoint, I know that sometimes when somebody's been on Oregon Health Plan, then they've already submitted their information to go through the process. Their concern is Oregon Health Plan going to come back to me later on because I've already, yes, I'm way over. My business boomed this year. I knew that it was. I've already advised. I provided the information, but I'm not gone through the process. So that's one of their concerns. The other concern is if they come off it right now, which some have requested to be off of Oregon Health Plan, but they've done it during open enrollment, then their next concern is the letter from Oregon Health Plan, is Marketplace going to accept it if it says that they requested it, because it specifically states it's not over income, it's requested by the person. So it's usually by no fault of your own. And if you're requesting it, then it is fault of your own that you're off of this. So it's kind of, how do I guide my clients as to which direction to go that is not going to cause them a problem with losing coverage through Oregon Health Plan, but not being able to get enrolled through Marketplace. So those are some of the things that I've seen.
Yeah, thanks, Gladys. That's really helpful. I think I'm sensing a lot of energy here. I'd like to maybe just have us bust the rest of these slides so we can get the discussion, because I think this is exactly the type of conversation that we wanted to have. So why don't we go to the next slide? So other flexibilities that we've gotten, and some of which we are planning to make permanent, applicants will be able to self-attest, especially to income, but pretty much everything but citizen immigration status throughout this process, meaning that we aren't necessarily checking that with other information. We've done expanded presumptive eligibility and have allowed more remote ability to be able to do presumptive eligibility. And then I think important to note, we have been doing the redeterminations where we can. So if we've got complete information, if people are sending us complete information, we are doing the redeterminations. What we haven't been doing is terminating coverage for folks who have been sending us sort of incomplete information or not following up. So what we have in our system is sort of a mixed bag of folks who at some point in the last 2 years, or maybe multiple times, have gone through the full redetermination process. We absolutely know that they're eligible right now, whether that, and then some folks that we have questions about, we don't know. The reality, though, is that, as I mentioned, CMS is requiring that states do eligibility based off of new information. So even if we know that they're eligible right now, or even if we suspect they're ineligible post public health emergency, it doesn't really matter because we do eligibility determinations on an annual basis anyway, and we will have to basically update their information at some point. What it does give us a read on maybe is, are those folks, more likely or less likely possibly to be eligible after the public health emergency, and that might help us with sort of how we stage some of this. It also gives us some information on who do we have current contact information for or not, which is also going to be helpful. We're planning to keep some of these changes permanent post public health emergency. One of which is continuing postpartum coverage. Where actually the federal government's allowed us to be able to extend that from 60 days to 12 months, and we're in the process of getting that approved and implemented. We are working on income verification that sort of follows self-attestation as opposed to waiting for income verification before we can get folks enrolled, and are looking to make that more permanent. We also are looking to, as part of our Medicaid waiver renewal, we're also looking to try to align income verification across SNAP and Medicaid so that if folks come in through SNAP and are eligible for Medicaid, they don't have to go through a second income verification. We're also, as a result of launching Cover All People, are looking to expand and build off of the CALM program, and be able to continue to provide a full benefit, or provide a full benefits package to folks. So those are some additional kind of eligibility changes that are in flight. Next slide. In terms of what federal guidance we have so far from the federal government, and this has shifted. The Trump administration and Biden administrations took very different strategies on what they're calling unwinding. I think one of the biggest being both timeline, extending it from 6 months to 12 months, but also this change of policy around needing to really do a sort of fresh look at everybody. While the public health emergency has been extended in 90-day increments, the federal government's committed to giving us 60 days notice before it ends. So we sort of have some read on whether they can extend it or not, or when they're going to start the process for redeterminations. When it actually starts will be dependent on when the PHE ends, though. The current guidance is that states have 4 months from the end of the public health emergency to get back sort of on cycle and into their normal process, or a process, and they have 12 months after the public health emergency to wrap it up. So those intervening 8 months between 4 months after the public health emergency to start and 12 months after to end, there is flexibility within that in terms of who do we prioritize? Do you front load or back load? How much notice do folks get to be able to get us information? What is sort of back on track look like? Largely, they're just looking for states to come up with plans that generally fit their guidance, and that'll be, as I mentioned, we just had our first conversation with them yesterday around that, and are trying to understand what flexibility there is. So there is flexibility within that 12-month window. What they're really wanting to see is that states have plans and that they will be basically caught up by the end of the 12-month period. And as I mentioned, there's still a lot that we don't know. Next slide. Our current plan right now, and I will say current plan because I think this is a discussion that we're having with you all, and we'll be having with other stakeholders and community partners and with the legislature this session. First is to really launch a robust outreach and communications plan, not just with members, but also with all the partners that need to be involved with helping with assistance or knowing that this is happening, so they can be talking to patients or members. We're, I think, at the very beginning stages of building out what that looks like. And I'll just put a plug in that I think, especially on the partner side of for the marketplace, I think really thinking about what sort of financial package out of the legislature resources are needed in order to be able to really have a robust outreach and engagement plan. And, again, this is sort of to the scale of something that we haven't experienced before, and are really thinking about building off lessons that we've had in the past, and thinking about where do we really need resources to be able to have adequate outreach and enrollment assistance. We're working on coordination between the health plan and the marketplace. Chickie's going to talk about what that looks like, but we're looking at a data handoff so that as we find out folks are ineligible for Medicaid, that information's handed off to the marketplace, who can then pick it up and do outreach. The current plan is to spread the 1.4 million folks out over 12 months pretty evenly. And I say that again, that's the plan as of right now. I think there's a lot of discussion that we're having internally, as well as discussion with the legislature around whether that's the right approach, especially with so many other things happening this year, and launch of Cover All People, some backlogs that we've had in our enrollment teams. Thinking about the upcoming open enrollment period, I think that is still up for discussion of how much do we want to begin immediately after the public health emergency ends, or is there a different timeline? Regardless, the process will be fairly automated on the OHP side. We'll wherever possible use information that we already have to renew folks. Those folks that can't go through an automatic process, that will kick into a manual process, and we'll basically have to do, a letter out to folks and an individual reach out to get information, but are looking at trying to do a basically pre-populated renewal notice. So folks who can't go and do it automatically, send them a form that has as much information pre-populated as possible. Next slide. So I'm going to turn it over to Chickie to talk about some of the handoff from Medicaid to Marketplace that the team's been discussing.
Chickie?
Thank you, Jeremy. Yes, I am. So Dan, did you have a question?
Yeah, just question for you. I was especially intrigued by Jeremy's third bullet. And as you present, Chickie, I would just ask you to highlight, what are we planning to do new on this redetermination that we're not doing now with people coming off of Medicaid, or we haven't done with previous eligibility transfers? In other words, I'm really interested, and I think a lot of us are interested, how do we push the envelope, make this as seamless as possible, and where do you need support from those of us on the committee or from others to make this happen? So I know that you're going to cover that, but just emphasize what we're doing new this time around.
Okay, so actually that is a fantastic question, Dan, where the team has been very focused on what's different and what can we do better. So the main difference will be, we will actually get enrollee level data as to who these Oregonians are who will no longer be eligible for OHP. We will know who they are, how to contact them. And one of the things we're exploring right now is really trying to repurpose the CCO 2.0 algorithm and use that algorithm to, for example, Katie Button, just no longer eligible for OHP. Katie was using all of these services and we're going to these providers while she was in this CCO. And then finding a way to map that information to find out, so what services and what providers are would be a really good plan for her to be crosswalked to. So having those types of information will be very, very important as we do targeted outreach to these folks. So that when we call Katie Button, we can say, hey, Katie, here was your usage. This is what your usage was in CCO. Here were the providers that you went to. And maybe here are the potential plans that would be similar to what you were using and seeing in your CCO plan. So that's one approach that we are starting to dive into. And then, of course, we also will be sending information to these consumers with, say, hey, you are this age in the Portland area. Here are the potentially the most cost-effective plans for you based on premiums and cost sharing. So that's the primary difference between what we currently do today for anybody who is determined ineligible for Medicaid or does not have employer-sponsored coverage, we will get we're hoping to get the data to do the targeted outreach and really walk them through the process of learning more about what marketplace plans are and their options. So what that means, Dan and team, is we are looking at, it becomes a case management process for us, and we need a whole team, a much larger team of folks to call these folks up, maybe set in-person appointments. So it's going to be a network of community partners, our agents, and maybe even more. We are looking at a larger call center, a larger team of business analysts to do this work. So 300,000, right? So our economists are forecasting about 300,000 Oregonians enrolled in OHP will no longer be eligible after the PhD. Even if we are able to divide that over 12 months, that's approximately 25,000 Oregonians that could come to the marketplace. So 25,000 Oregonians that we will be doing targeted outreach and then working with them to do their enrollment through healthcare.gov. So approximately, and I could be wrong, initial estimates were average of about 2 hours per OHP no longer eligible person that we will be going through this process. And I see already Shannon nodding her head, and I'm sure some of our community partners are also thinking 2 hours might be it could be a conservative estimate. It could be any. So we're just really trying to figure out how to make this as seamless as possible because we are on healthcare.gov. So we are not able to auto enroll anybody, but we are able to do targeted outreach. We will be marketing, of course, and then working with our Medicaid partners for the member communications to be as thorough as possible. So lots of details in that brief spiel, Dan. But where we need help with is ideas to make this process more seamless, or at least what else can the carriers do, our community partners, our agents do in the marketplace? What else can we do together so that this targeted outreach piece, which will be highly manual, it will be very, very manual. What else can we do to make this more seamless? Yes, Ann.
Can I just ask you about that auto enrollment piece? And I don't want to get too much in the weeds, but I know that would be a huge change for us. Have you talked to CMS or the marketplace people nationally about that? We do have a different presidential administration who has an interest in continuous coverage. And I realize that's not normal functionality on the federal platform, but that seems like an interesting innovation we could propose.
So it would be a fantastic feature. However, none of the states, even those that have their own SBM platforms, will be able to do auto enrollment off the cuff. A lot of it because we do not have authorization to do so. So there will always be some form of consumer component that they will need to agree to be auto enrolled from a Medicaid plan to a marketplace plan. So that's not something that any of the states have. So that's one piece, one part of my answer to you, Dan. Another is healthcare.gov has already said, and they are very, very, they're very set on it, that their eligibility system, enrollment and eligibility system cannot allow and will not allow auto enrollment. Gotcha. Thank you, Chicky. That's a terrible answer, but very helpful. Not the answer I wanted. So I know some states are thinking about it. I believe it's California that's also thinking about legislation to allow it, right, to allow auto enrollment. They do have a much bigger population, so they are severely concerned about it. And for contact, they are thinking of crosswalking folks, I believe, to the lowest cost silver plan. Yeah. So for any state that's considering crosswalking, it's to the silver plan.
And Dan, I think there's a little political context that's useful here too. I think while we're in a state where we are desperately trying to figure out how do we not lose 300,000 folks and how do we create a smooth transition for them, that is not the problem that CMS or the feds are dealing with some other states who are slated to drop millions of people, as soon as they can, for a variety of reasons, backlogs and applications, state budget issues. So I think there's kind of they would like to be where we are and they want to be supportive of us. And at the same time, they're just spending a lot of energy trying to figure out how to protect members on the opposite end of the spectrum.
I didn't know that. That makes a lot of sense. Thank you, Jeremy.
And Sean, before I call on you, next slide, please, because this will be the visual that will, sorry, one more. This is the visual that talks about the current plan for the consumer experience. Sean, go ahead.
Yeah, I just wanted to mention that when people do get crosswalked currently, one of the common complaints is just that they feel like they're going to get sent to collections if they don't go with the plan that was selected for them, as if that has already been finalized and whatnot. If it's able to be clarified in the notices and whatnot that this is not like a final decision until they actually pay for it, that they don't owe the company any money or they're not going to get tax credits back on them, it just makes it less of a stressful thing, like, oh, the government's signing me up for this bill that I can't pay for. Some folks will always run into that situation, and we can kind of de-stress those folks at least by making it clear that none of this is final until you've actually paid this bill.
Thank you, Sean. Very valuable feedback. So wanted to clear up though that we are not doing any crosswalking, right? So to Sean, to your point, there is no auto enrollment, there is no crosswalking. It's not even a recommendation is however you just define it, right? But we would like to be in the business of providing as much information as possible and making it easily accessible as possible so that these consumers know their options. And hopefully the process will be easier for them. Okay, Sean, go ahead.
Sorry, I was referring to the current crosswalk folks from last year having that experience just under current crosswalking from marketplace to marketplace. But just if we put dollar numbers on anything, making it clear that this isn't effective until we start paying is just helpful to make it clear it's not a bill that people are expected to pay. This is the price that you would get.
Okay, that makes a whole lot of sense. So thank you, Sean. Okay. So I think this is actually a really good time to segue, and recognizing it is already 11:33. This is a good time to segue into Katie. She has some options for maybe, so aside from this this current plan of how we are going to be able to help migrate folks over to the marketplace, we are also thinking about, are there other options? Is there a bridge plan option in the marketplace? What is important to these no longer eligible folks for us to be able to provide the information to them? So what actually you have in front of you is some of the feedback from the Marketplace Community Conversations. They were very valuable points of information for us, and we will continue to dive into those within the next couple of weeks and months. But recognizing we are running short in time, Katie, please kick us off.
Thanks. So Dawn can kind of scoot forward a few slides because you all know how complex marketplace plans are and why we're considering doing some sort of crosswalk. So, so this is perfect, Dawn, right here. So we're thinking about silver plans because cost sharing reductions and most of the premiums covered by tax credits. And so as Chicky mentioned, so right now we kind of have these couple of options where we're hoping that we can do this algorithm that will let us see where folks are accessing providers and hopefully be able to connect them to a plan that contains their provider and be able to display that plan to them. And then we can also do some crosswalking on actual, like these plans kind of contain benefits and services that are similar to what you would see on OHP with hopefully not too much sticker shock. Dawn, you can go on the next slide, please. Oh, Chicky, do you want to go over this one or do you want me to go over this one?
Go ahead, Katie.
So there are a lot of ideas out there where we're just thinking of things are, you know, could we potentially get some money and just help folks stay on OHP for longer? And then there are some other options like maybe developing a new marketplace plan. Right now we're calling it the Bridge Plan. It's a very exciting name, I know. Andrew, would you like to ask a question?
Sorry, it was back on the prior slide when you're proposing an algorithm. Do most CCOs require a PCP assignment, and why not use then the PCP assignment as like the core of like, well, is your PCP in the new marketplace network?
So the reason that we are looking at most used providers is because we know there are a fair number of folks who might not see their PCP, they might see another provider more, but also there are PCPs who don't accept commercial coverage. And so our hope is that if we can crosswalk at least a few of their providers, that we can find hopefully one that they see a lot who is in network. And so, you know, if you need to find a new PCP, but at least you can still see your mental health provider or your physical therapist or something like that, it might lessen the shock of the transition. Don, go to the next slide, please. So these are kind of the things that we're thinking about as far as keeping people in their CCOs longer. Basically, is can we get some money and give it to Medicaid, and then the people can just hang out on their CCO. Next slide, please. And then a bridge plan. So we could think about a plan that we could offer now that we wouldn't have to get a waiver for. We wouldn't have to do anything funky with state and federal requirements. We could just use what we already know about designing plans and create one. And so we were thinking about that if you started with the 94% cost sharing reduction and worked your way back down to the base, that you might be able to come up with some more sort of creative plan design, if you will. And then thinking about, Don, go to the next slide, please. Sorry, I'm trying to make sure we have plenty of time for discussion, and we've kind of already talked about a lot of these things before. So the premiums on a plan that has benefits as close to OHP as you can get while still staying, you know, within AV for marketplace, they would be high. So we would have to think about some solutions for folks to help lower those premiums. So might be trying to leverage the CCO networks and you know, have folks still access those networks through their commercial plan, reducing provider rates, maybe some sort of premium sponsorship program. There's a lot of options out there. If you use the silver plan, one of the drawbacks is that the most significant benefits are available for individuals who are at or below 150% of federal poverty level. And so as people increase, their benefits would be more expensive. Next slide, please. So Chicky, this is getting into the last section. Chicky and Shannon and Dan, sorry. I know there's many facilitators today. Do you want me to go here? Do we want to stop for a minute and talk about the crosswalk and the bridge plan?
Let's do that. If you can go back to one slide, please. Okay, so the Medicaid to Marketplace Bridge Plan, initial thoughts and reactions to it, please.
Andrew.
When we're saying the carrier would leverage the CCO network, is it implied that it also leveraged the CCO payment rate to the providers?
Yes, that's the idea, is that basically if you could get the providers, get the lower reimbursement rate that CCO providers are used to, or maybe providing them with a slightly higher reimbursement rate, but not the same as commercial carriers, that you could keep the premiums low enough for folks to be able to afford that plan.
I will add, I mean, so I think to provide a bit more context here. So I think as we've been thinking about bridge options, it hasn't been about, I don't think we're not trying to solve a problem of necessarily with folks who are struggling today with affordability in the marketplace or trying to solve that issue, although certainly we know that's an issue. I think we're really trying to solve the issue of we know there's significant churn, and we know that there's a significant number of folks that pre-pandemic who were uninsured and clearly eligible for OHP or the marketplace. Now they're in, and now we know the churn has stopped. And I think as we've talked to even, you know, community partners, but we've certainly welcome feedback from this group, you know, I think what a lot of people are expecting is that a lot of these folks will become uninsured again, regardless of whether they continue to be eligible for OHP or the marketplace. Continues for OHP because they get stuck in sort of, you know, bad addresses or stuck in the, you know, struggles of navigating the process. Marketplace, probably some combination of don't understand it, it's confusing, or it's still too challenging as you go from paying zero to having to pay more. So I think the idea here isn't to try to reduce reimbursement rates just to reduce reimbursement rates. We've been trying to figure out, is there a plan or a program that really extends out CCO coverage, keeping people where they are, and can you do that with the existing federal dollars? And really the only way you pencil that out is to say, find some reimbursement rate that's between Medicaid and commercial to try to keep costs down. I think no provider loves that idea, but I think the alternative, one of the alternatives that we're worried about is those folks becoming uninsured, right? And there's no reimbursement, and they aren't getting care that they need. So that's been the purpose here isn't to drive a conversation on reimbursement. I think the purpose here is to drive a conversation around continuity of care. And is there a way to design a program that stays within the federal dollars that are available and as budget neutral to the state as possible, and preserving care?
Dan, I see your hand up.
Yeah, that's super helpful, Jeremy, because the question of what we're trying to solve to has been kind of elusive for me. So we don't need to change the slides, but if we were to just in our heads go all the way back to Cable's open enrollment slide and remember the average number, what was that, $56 or $86? Does anybody remember? It was under $100. And if you could solve the administrative gap, the challenge of navigating onto the marketplace, what you're left with then is the financial gap. Jeremy, to your point, we know for a fact, you're right, that even a very low cost sharing is a barrier to some people, especially rolling off of a no cost sharing Oregon health plan. But I just am left wondering, wouldn't it be easier to target closing that financial gap in the marketplace plans rather than creating a new lookalike, I would call it, that sits alongside the marketplace, a new lookalike bridge plan? And that's just kind of what I'm thinking about, and where I'm still not totally convinced that if the goal is make it administratively easy and make it financially seamless for this pretty narrow population, what's the best way to do that? And I don't know that we've fully explored the opportunities to do that within the context of the existing marketplace plans.
I see Andrew's hand, and then we'll go to Lindsay.
Thank you. I don't know every CCO really well, but I do know HealthShare, and the network, the behavioral health and other components of the network are not all integrated with sort of each carrier. So some of the CCO's network development is, I won't call it messy. I mean, it's what was intended at the time of the CCO creation. Moving that network into a marketplace actually could be more just operationally messy. And I'm not necessarily proposing a solution, but I wanted to, I guess, maybe get a little bit more into the mind of the solution of what maybe was in Katie's mind when preparing the slide. Is the intent that CCOs would then be the carrier within the bridge, quote unquote, plan? Or is it more traditional carriers that would be the bridge carriers?
So this would be a plan that's available on the marketplace, so that it would be the regular carriers unless a CCO carrier could meet the requirements and apply to participate. So it's kind of a back end kind of thing, like I know in the past, certain carriers have leased networks from other carriers. I don't know if that's, sort of kind of like in my mind, that's kind of what I've been thinking about. But it would definitely be using the relationships that the commercial side has with the CCO side and that to see if there was something that we could do there.
Thank you, Katie. Lindsay?
Thank you. I think looking at a bridge plan, it seems like it seems a little complicated to me to add another additional layer and another type of health insurance that someone could get onto, especially if it's going to be temporary as a transition from someone being on OHP to getting onto the marketplace eventually, is at least, like, and correct me if I'm wrong, Katie, but that's kind of how it's sounding to me right now. So my thought, of course, goes to what if we did some kind of premium assistance, or what if, is there a way that we could use those federal dollars to pay for people's marketplace insurance premiums temporarily and help them out in that transition to getting onto the marketplace and staying onto the marketplace, but eliminate that financial burden. And then I would imagine for many of the people who are in that transition transition space, one, their premiums are going to be super low because of their tax credits. And then two, many of them would qualify for hospital financial assistance, and we could increase education about that and help people reduce their out-of-pocket costs. Also, so that's my thought.
Thank you, Lindsay. Sean?
Yeah, one of the things that seems to be one of the major benefits of this to me is that it gets the state some practice on the move towards a public option or something along those lines. This also doesn't seem to be necessarily a coordinated effort to be the bridge towards that, though. So I'm a little bit reluctant to create additional safety nets because there's always gaps between those. And if we're creating more and more systems for people to keep track of, that increases the complexity, not decreases it. If it is this is supposed to lead us to a public option, though, it does make a lot of sense for the state to start with a pilot program type thing and expand from there. My level of support for this would vary significantly depending on how integrated it is with those future plans, I guess.
Thank you, Sean. I say I had just a couple of comments when we're focusing on the premiums here, but the other big piece is out-of-pocket maximums. Oh my goodness gracious, and being aware of kind of calendar year changes. So if a client did lose their Oregon Health Plan December and their deductible restarted, and then it's going to restart again in January, that could be extremely impactful, especially if that person's in the middle of receiving care. I think too, the numbers that Cable shared in the beginning is based on the ARPA and those increased tax credits that families are receiving. And as we just heard from Stephanie, that might not be around in 2023. So it could be a double or triple whammy for folks that are transitioning out of these programs. And I think the continuity of care is definitely the most critical. And then simple, right? Like making things as simple as we can for folks transitioning. And it is such complex work. There is so much coming at the state and so critical for the health of Oregonians to get this right. And it's going to take all of us, right? So many different folks represented here with the Marketplace Advisory Committee, and it's going to take all of us together to make sure Oregonians keep health care and then keep accessing care for their health needs too. Any other, Craig?
Yeah, thanks. I'm going to make a few comments about this. Hopefully they're applicable, but one is I would assume a bridge plan wouldn't go into effect until 1/1/22 because of filing. So we may have a period of time if the redetermination starts in, I'm sorry, 2023. So if it starts in, I don't know, the fall of this year, we're gonna have people, some portion of people, if we're doing it uniformly over time, that have access to it and some that don't. So that's one thing that comes to mind. And then I would think anyone could choose these plans, not just people coming off Medicaid. So you have some disruption and migration potentially in the marketplace. We'd probably want to think about that. And then I think the last thing is introducing some lower cost options has that without a waiver has potentially negative impacts on the federal money that we get through APTC from the government. And so there's some things we probably want to consider there as well, if I'm understanding this correctly.
Thank you, Craig. Said a lot of great conversation.
Shannon and Chicky. Oh, sorry. Go ahead.
No, go ahead. No, you're fine. Go, Katie.
I was just going to say, I will defer to you on whether or not we want to go through the next slides, or those were kind of like a little bit of a different topic. So if we need to cut so we can finish the rest of the agenda, I will defer to you two.
And I am going to defer to Chicky, actually. Chicky, what route would you like us to take?
And here I am as I find my copy and try to scroll ahead in time to answer your questions. I think we have plenty of information for now. I think that these other questions we can address offline or at a future Marketplace Community conversation. So I think if we can spend 5 more minutes to talk about any other considerations for the Medicaid redeterminations, this is very, very important to us because it could end as soon as April, or it could be extended. And we really need to make sure our approach is thoughtful and comprehensive, but at the same time realistic.
Shannon,
Dan?
I just want to, I want to acknowledge that you guys can tell that I have questions about this. I know others have questions as well. And I just want to acknowledge the great work done by Katie, Jeremy, Tim, and others. This is really, really complex work. It's also why Oregon continues to be on the leading edge of innovation, and why we're not really drawing on experience from other states, except in some limited circumstances. So even while I'm sort of poking holes in some of this and others are raising concerns, that tells me that this is the way this process should work. And it all starts with Jeremy and the staff that are willing to do the thinking behind this, and bring these ideas forward. And I just really want to acknowledge that, regardless of where we land with a bridge plan, with something else. This is the conversation that should be happening in 50 states and frankly in Congress, and it's not. And so the fact that we're doing this heavy lifting here in Oregon is a source of pride for me, and I hope for all of you. And at the same time, when you're on the leading edge, it's hard work, and there's a lot of questions with these ideas, but let's continue to push and probe. And I love that we're unified by the overarching objective of those 300,000 Oregonians. And I know we're all laser focused on meeting their needs, and that's a good feeling. That's enough speechifying for me, Shannon. Back to you.
Oh, thank you, Dan. I think Mary Beth had her hand up.
I just have a really quick question, and that is what we're working on. And I think I would echo Dan's comments. I think this discussion is really valuable, but I would be curious if there's anything that the legislature needs to do in order to help us in this process. And if so, are we going to be able to get it done in February, or given that the fact that the public health emergency might be extended again, are we going to need to push that down the line, what that looks like?
Yeah, I can speak to that, Mary Beth. So there is a placeholder bill in House Healthcare. I would say this is probably one of the more uncomfortable spots I've ever been with the legislature, of not having not having something baked for them to really react to. But have largely been talking about the need for, I think, sort of three main buckets of some direction, or at least discussion. May not be that they all ultimately end up needing statutory change or resources, but I think there's what is our overall plan going to be for working through this, and in particular things like how do we leverage partners, what's outreach and enrollment assistance that we might need from the legislature that might require some resources. Just basically what's our process going to be. I think there's a second piece around this, around timing, and what's the willingness or interest in slowing this down or spreading it out, and the budgetary impact that could have. And then I think the third is there something that we're actually aiming for beyond just getting through the redeterminations? Are we looking to actually try to fill a gap in the uninsured rate here and reduce churn as part of the process? And is there a mechanism through, bridge plan or waiver or some other authority that helps with that? And I think we need to do 1 and 2 regardless. And so I think the question is there for the longer term piece, is there a spot that the legislature and stakeholders are comfortable with us saying, try to explore this other option, or have a timeline to be able to do that. But in the meantime, we've got our baked plan for how we're going to go about redeterminations regardless. The timing of this, a lot of questions have come up. Well, can we really build something? Do we have enough time? Should we be building, some longer term options that come back in the 2023 session? And that really is where the timing issue comes into play. If the public health emergency is extended all the way out to September, October, possibly, you would, even in that case, you'd have to start redeterminations pretty close to the first of the year. If the public health emergency timeline sticks where it is right now, we would have to be pretty much done with redeterminations by the end of the next legislative session. And there really isn't another legislative conversation to be had. So that's the balance that we're struggling with, but expect to engage with the legislature and stakeholders over the next several weeks on all of that, and ultimately land on what direction do we need. I think direction, at least on the overall timeline of and process, is going to be important one way or another.
Thanks.
Thank you. Well, we are running a little behind, which I'm sure we all figured. This is just wonderful information, and we all have a lot to share. I appreciate everybody's willingness to share and echo what Dan said. Appreciate the staff's hard work. There's still more to be done. But thank you so much for getting everything ready for us to have some great conversations. I was going to kind of flip actually the last topic and do public comment first, as we're almost at time, and I want to make sure any members of the public who want to speak can do so in the time allotted. So I'll make some space for any public comments. I say I appreciated during this meeting that we had some public comments kind of sprinkled throughout our conversation. It worked really well. So thank you for those who shared. Sometimes it can be a little intimidating sharing, but I appreciate folks who were willing to share. All right. Well, hearing none, our next item is service recognition. We have a handful of us who are going to be departing. It's been great. I'd like to call on folks if they'd like to share a few words. That would be great. And if you don't want to, you can put it in the chat too if you'd rather not share verbally. We'll start with Shauna Butler. Shauna is still with us. Say, Shauna, are you there? No, well, we have appreciated having Shauna on the Marketplace Advisory. She represents the agent community and always has just a great perspective to share and is doing the work on the ground with consumers. We have valued her input and will miss seeing her. Dan.
Thank you, Shannon. You guys have heard enough from me today and over the last 6 years, so I'll keep it short. It's been a real honor. And I'm actually just really, even though I missed a little slice of it, I'm so tickled that today was the last meeting because it was so substantive. It was so thoughtful. It reflected the feedback we get from really frontline people like Lindsay, Sean, Shannon, who are able to both think about things at the individual member level, but also at the system level. I appreciate the carriers, Ken and Craig, coming forward. And, you know, we need a healthy insurance community in order to make these plans work. And I think we have a really robust marketplace in Oregon, and I'm proud of that. So I won't go around the horn and acknowledge everybody, but I just want to say thank you. It's been a great experience. Sometimes we've all been on a committee or a work group or a task force, and it's such a drag. You can't wait for the last meeting. And this has kind of been the opposite. Who would have thought after 6 years, I'm sad to be leaving the group, but I am after 6 years. And I just want to say thank you to all of you, Chicky and the staff. It's been a great experience, so well supported. And it's been an honor to play a small role in this process. So thank you all.
Thank you, Dan. Jim.
Thank you, Chicky. Yeah, I can say never, whatever, 10, 11 years, 12 years ago that I ever would have imagined that I would become so deeply involved and my head so full of healthcare values and policies and programs. I'm just very honored that I was able to participate in this and hopefully provide a perspective. I have to say I thank Jeremy. Jeremy's the one who, over 10 years ago, 12 years ago, invited me, challenged me, encouraged me to become involved. And I've seen Jeremy's role and Jeremy blossom. Katie, I've known Katie throughout almost this whole process from back in the days of Cover Oregon. I've hung on longer. I think I was only supposed to be 6 years, and it's been 9 years, I think, with this or more. But I've certainly learned a lot. I hope I contributed to the understanding that I'm sorry I don't have anyone to bring forward to take my place. We somehow need to build that into this. You can't leave until you've found somebody to replace you or something. But it's been fascinating. I don't intend to stop my advocacy. And in fact, I'll be probably speaking before, testifying before some part of the legislature about our plan that we formalized in September of 2019 to convert to a fully state-based marketplace. I still think that's going to be essential, especially as we want to add so many of these other possible features and benefits. So I just thank everybody so much for helping me along this process. Everybody else here has so much more understanding with the material, and I feel very honored, and thank you all very much.
Thank you, Jim. Sean.
I just want to echo everyone's comments. It's been a wonderful experience serving on this committee and working with so many great experts in their field and figuring out how to make things better for Oregonians. It's been a truly gratifying experience. I'm glad to have the opportunity to do this through this committee and continue doing that going forward. I would be remiss if I didn't mention my support for the continued movement towards the state-based marketplace and those issues, as well as those trying to encourage those hospitals to start financial assistance programs to both better use their own funds more effectively and serve patients as well. I'm going to miss all of you, and it's been great having these discussions with you regularly over these years.
Thank you, Sean. And we don't have Ken with us today, but he's been a wonderful member of the HIMAC committee too, and it's been great getting to know him and hear his perspective from the carrier side of things. Last is me, Shannon. I've really valued my seat at the table so much. This was my first experience at state level committees, and I'm surprised to hear that not all of them are this fun. So I've really, really enjoyed my time and have felt that my time is valuable. I've really felt listened to, and that is so important. So I just such wonderful people. I've appreciated working with all of you and all of the staff too. I feel really informed on what's going on and just felt like I was my voice was valued, and I've really appreciated and been honored to have a seat at the table with everybody. So thank you very much.
Thank you, Shannon, and thank you, everybody. So from the Marketplace team, I will say thank you for spoiling us. You have made our job so much fun. You are my first committee. I've been the administrator for 4+ years. I probably will not take any other committee ever again because you all have spoiled me. I have loved working with you. I know the team just always just like, hey, what about this? What about that? Let's talk to the HIMAC because you're also collaborative. So thank you so much. Yes, you are departing, but I refuse to accept that you will not join our meetings in the future. So please know invitations will still come your way, content will still come your way, and we look forward for you to participate. Even if you're not a formal committee member, you are always going to be a committee member of the HIMAC. With that said, Shannon, we do have also a fantastic group coming through. Senate confirmation is happening in a couple of weeks, and I know many of them were able to join today. So thank you to Ines, Andrew Tara, Paul Harmon, Gladys Boutwell, Holly, Neshoba, Lindsay Hopper. Thank you so much for accepting the challenge of replacing these fantastic, lovely legacy folks. We have a lot of work to do still, so thank you so much. Our next HIMAC meeting is in April. We may have something a little sooner than that to talk about the marketplace fee for 2023, as well as anything that comes out of the 2022 session. I've posted a link to the House bill that's the placeholder for public option redeterminations, all of that fun stuff that we just talked about. I know we're over time. Thank you so much, everybody. Dan, would you like to wrap this up?
Thanks, Chicky. On behalf of Shannon, the vice chair, and everybody else who is rolling off, I just want to say thank you again. This is a really strong group. We have strong new members. So the work will continue, and we leave you as proud participants, soon to be proud observers. And so thank you, and thank you, Chicky, and just wish everybody the best. We will see you down the road.
Great.
Thank you.
Thanks, everyone.
Take care, everybody.
See you all later.